Hope you had a lovely lunch. Post-lunch today, we are having with us Dr. Leonardo Longo, the Leonardo da Vinci of lasers. Leonardo has been in the field of lasers for over 40 years now. He also happens to be the president of the World Federation of the Society of Laser Medicine and Surgery, with over 300 federations under him. He also is the president of the International Academy of Laser Medicine and Surgery and the past president of the International Society of Laser Medicine and Surgery. He specializes in non-surgical laser treatment. And today he's going to give us a talk on non-surgical laser treatment of traumatic central nervous system injuries. He has a book on laser mechanism, laser manual of medical technology, and with having attended over 400 international conferences and 300 papers peer-reviewed, with 5 of his own books, and he's also authored in 15 other books. Let me welcome Dr. Leonardo Longo to take on this dais. Welcome, sir.
Thank you for interesting presentation. Do you sleep? No? I would like to speak about this very interesting topic because this topic don't have a very good therapy until this moment. At first, my disclosure, I am supported by myself, my staff, my patients, my wife and time, and also my family. I don't have some manufacture industry, unfortunately. The selection criteria for data in the human experimentation must follow the Helsinki Declaration rules. So we must measure the data, we must to repeat the data, we must reproduce the data. But this is only one part of the science, because the other part is the scientific observation, as Wischoff said. Wischoff said that at first we must study the facts, and then the causes of facts. I like very much the approach of World Health Organization that say that we must study and verify each substance, energy, tool, which modify a physiological process of the human body. The effects of non-surgical laser light on nerve cells were studied from many years, from Fork on the aplasia of peripheral nerve, from many authors also in this room. There are many authors which study about this in the experimental point of view. The books are some laser fluorescence proceedings, printed 5 years consecutively from SPIA, America, 5 years from American Institute of Physics, and now by Medimont Publisher. And the last book is my book, Laser Manual. Nomenclature is important. Just yesterday, James Carroll defined the nomenclature, but I use only laser, not LED, not pulse light. So I like to change the nomenclature, not low level, mid level, high level, but I prefer to speak about non-surgical laser therapy, instead surgical laser therapy. The patient selection criteria was described in my previous publications, and we included patients with traumatic spinal cord injuries, with large amount of age, 15 until 60 years, lesion occurred minimum 1 year ago and more, until 35 years ago, one patient. And nuclear magnetic resonance or computerized tomography say the lesion is total or subtotal, and the ASIA impairment scale is ASIA A, maximum ASIA B. No therapy advised, and we stop each drugs progressively, and included pump with myorelaxant, and rehabilitation fitness continues. We exclude the patient with previous surgical intervention contra nature, for instance, the transposition of muscles of the shoulder, the cutting of tendons, etc., etc. We exclude the patient without results after the first cycle of laser. We exclude the patient with use drugs, but also marijuana, cocaine, and toxicodependence. And we exclude the patient with stop physical therapy without authorization. And summarizing, we treated in the last 12 years 289 patients in total, and 67 patients discontinued the treatment for different causes, and 9 patients were treated only for traumatic brain injuries, and 213 patients were treated for traumatic spinal cord injuries. The parameters are summarized in this slide. We treat patients for with more lasers. It's a multimode treatment with basically 880 nanometer, is 10,600 nanometer, and 1,064 nanometer. But I treat patients also for different goals, for the anti-inflammatory and anti-edema goal, for tissue regeneration goal, for to influence muscle tone, to influence the neuropathic pain and the inflammation peripheral. We perform more cycles. At first, we perform 3 cycles with interval of 1 month between the cycles, and 4 sessions a day. This is this picture would like to show that I don't use laser of one manufacturer only. I have about 20 lasers of 20 different manufacturers. And before the treatment, we must remember some very interesting and very important concept. At first, that similar central nervous system lesion in vivo don't exist, because the nervous system lesion, traumatic lesion, are always different. Always we have different loss of function. Always we have also different answer to each therapy. And the anatomy and the function often are dissociated. And so these lesions are not totally measurable, are not reproducible, are not repeatable. So for the traditional medicine, these lesions don't exist. Diagnosis and therapy evaluation of central nervous system traumatic injuries so have this problem that statistic criteria are not totally valid, because there are too much variable parameters simultaneously. So the lesion is always different, and we cannot follow always the regular medicine, the regular scientific disposition of the medicine. So also the protocols of diagnosis therapy are relative, not absolute. Why this? Because when one patient goes to Atlanta Spine Center, Toronto Spine Center, etc., the patient is evaluated with a lot of international scales, but all this is relative. But the patient have the assignation of one number, one score. When the sum of the score arrive at the same, at a certain level, the medical doctor say, yes, you can be treated with success, or not, you cannot be treated. This diagnosis is totally wrong. Evaluation of the treatment. We must use more tools of evaluation. At first, the international scales, a score, modified Ashworth scale for tone muscle, others, and the self-evaluation also of patient, of the person around the patients. Also the nuclear magnetic resonance instrumental diagnosis, and the electromyogram, the surface electromyogram, they evocate the potential somatosensor and somatomotor, and also the measuration of the force and dynamometers under the lesion. In brain injuries, we can use also the electroencephalogram. This is the schema of ASIA classification. ASIA is not a continent, it's American Spine Injuries Association. As you can see, we must evaluate each key muscle, each key sensation. We give a point, and the sum of the point decide the patient where go. This patient is classified in 5 different groups. The first degree, a complete lesion, A is no motor or sensory function under the lesion, and the E is totally normality. Usually the popular credence in medicine say that when we have a complete A lesion, it's not possible to improve this lesion. We can demonstrate exactly the contrary. This is the Ashworth scale for the evaluation of the muscular tone. This is a series of evaluation when we have brain injuries. The evaluation we must see in detail is clinical evaluation. Clinical evaluation is good, but is the only system that we have until today. But it's not totally objective, it's not totally measurable, it's quite reproducible. And the evaluation of instrument, nuclear magnetic resonance, tomography, XR, this evaluation is objective, but lesion is not totally measurable, because with all the instruments we have always a blind angle of about 25 degrees. But this measuration, fortunately, is good, reproducible, repeatable. But another limitation is that often we have dissociation between anatomy and clinical finding. For instance, this is a patient treated by us in 2006. This patient, the lesion occurred 2 years ago, T11L1, with complete lesion at the dislocation of vertebral bones. This patient stand up and walk after 1 year of treatment. This patient continues to have the lesion until 2011, when the lesion show with this tomography the new column of tissue which unit partially the lesion. This is the patient. This patient, this is after 1 year and a half of treatment and about 134 sessions. Now this patient use only the bot and the ambulator. We don't use the chair. Continuing the evaluation of this patient, superficial electromyogram and the electromyogram classic. This measuration is, yes, objective, reproducible and repeatable, but this measuration have some limitation because different condition of the skin and the different point registered change totally the results. And we can measure only the on-off activity. The evocated potential is more objective. We can measure nervous signal quite totally, is reproducible and repeatable, but we need a lot of needles to use in this type of test. And the dynamometer is another measuration objective. The muscle force is quite totally measurable, is reproducible, is repeatable, but this measuration need hard training, and the scientific international community still don't accept it because there is the risk to measure the force of the table, of the operator, not of the patient. This is one example of surface electromyogram which measure the possibility of the passage of the stimulation from the brain to the muscle. As you can see, this patient is a woman, since 2007 here she had a lesion T10, Asia A. With 40 sessions, 2 cycles, on the left we have activity, on the right less. The same patient with another muscle had a situation totally different, as you can see. Another patient have another totally different answer. 43 years ago, since 1995, lesion T4 Asia A. But we need about 60 sessions in total before to see activity on the left and on the right legs. Summarizing, we treated the patient in C2, C4, 15, and 45 in C4, C7. Yellow are the patients which abandoned the therapy. We treated a lot of patients with thoracic level lesion, patients with lumbar lesion, sacral and coccyx. Patients without results after 20 sessions were only 6. 3 cervical level and tetraplegia, 1 thoracic level, 1 lumbar level, and 1 sacral level. 67 patients on 289 interrupt the treatment. The 6 for no results after first cycle. Others for less results. These patients were not patients. Sometimes we have the incorrect rhythm of the cycles. The patient which would like to perform one hemicycle after 1 year is no good this. Sometimes patients say this is expensive therapy. And in 3 patients we have temporary results, but one patient had another lesion on the same place of the first lesion, and another patient exaggerate with physical therapy, and another patient exaggerate in opposite, stop the total the physical therapy. Perhaps in these 3 patients, we had again edema, again inflammation around the lesion. For this reason, we have a negative follow-up. On this patient, in this moment, we have 3 patients are continuing the treatment. 60 patients stopped after 1 cycle. 38 stopped after 4 sessions, 2 cycles. 50 patients stopped after 60 sessions in average, 29 after 100, and 45 more than 100 sessions. And 35 patients work with tutor and other. And they arrived from Asia A to Asia C and Asia G. Nobody Asia E. But the goals of the patients are a bit different respect to the people which look this patient, because the improvement requested by this patient are at first tactile and thermosensory under the lesion. They normalize the sphincters, the proprioception and posture, the pain, the muscle tone and thermal regulation. These are the goals of the patient. For this reason, sometimes patients stop the therapy after the goals are arrived. The last but not least is sexual activity. Many males stop the therapy after the normalization of sexual activity. And only few patients hope to stand up to working. In brain lesion, traumatic brain lesion, the first goal is to come back with psychological activity. Summarizing, we say that the result is positive when the sensibility increase minimum 2 metamers level below the lesion, and the involuntary motor improve in muscle tone, posture, minimum 1 degree, minimum 1 degree for cycle in one direction, up, down, right, left, and the voluntary motor muscle have variable improvement depending by physical activity. Anal sphincter improve anti-normalization in average after 80 irradiation. Ureter sphincter don't improve neither, fortunately, in the men, but in the women we obtained the normalization. Sexual activity is quite normal in 90% of patients, in average after 100 irradiation, and 167 patients stand up but don't walk, and 35 patients work after, in average, 120 irradiations. The ASIA classification improve each 6 months by 1 degree in average, And also the instrumental diagnosis give a lot of improvement step by step. In brain traumatic lesion, I have less experience because I treated only 9 traumatic lesions. But this is a very good patient, very interesting, because he was a patient male, 48 years old, with brain traumatic hemorrhage occurred in 20 years ago. He had a coma for 4 years, a 2 neurosurgical intervention for subdural hematomas, and convulsion spasticity for more than 10 years. He arrived in our consulting room with total right motor hemiplegia, partial right sensory hemiparesis, right facial paresis, dyslexia and dysphonia, and the electroencephalogram had the total absence of normal activity on the left hemisphere, maximum on temporoparietal region, with low comprehension and expression, loss of memory, edema of right arm and leg and foot. We treat this patient with the dosage shown before. Please note the target was right hemiface, the limbs, and the coherence domain at the first cycle. The other cycles, we treat only the coherence domain, called chakra here in India, in other countries. We performed 5 months of applications, and the result is this. After 5 months, we have the left focal temporoparietal sufferance with Asver under stimulation. These patients have the activity of the cerebral activity come back gradually. After this exam, this patient have further improvement. So, after further 6 months, this patient presented 50% of improvement of right motor epiparesis, 90% right sensory hemiparesis, recovery right facial paralysis, no dyslexia, no dysphonia, the electroencephalogram we see, and the improvement of comprehension and expression, normal memory, edema right arm and hand, disappearance of edema right legs and also of the foot, and return the sexual libido, return of the memory. The question is, the improvement of these patients could be spontaneous or caused by other therapies, as physical therapy alone, or only for miracle. And the cause-effect ratio between laser and results is not controlled, is not scientifically demonstrated. And the follow-up? And side effects and complications? The answers are 39 patients stopped laser treatment for 2 years and more for personal reasons, for work, for many other reasons. These patients, when they come back to continue non-surgical laser therapy, the situation of these patients was the same than the moment they stopped the treatment. So this fact demonstrates that the follow-up was positive, as all the rest of the patients. And once they restarted the therapy, the improvement restarted too. It's only spontaneous? It's only casually? I don't know. Side effect is only skin burns of first degree for some reflection of the ray, but it's very, very exceptional, and the recovery is total. Complication for patient, we don't have complication. For medical doctors, yes, because we eliminated the pump with myorelaxant. We eliminated 6 pumps. And this is leasing for the drug manufacturers. When I eliminated the pump, the drug manufacturer is not very happy. And there is the jealousy of colleagues. There is more political reason for physician, not for patient. The hypotheses of action mechanism are very much. At first, hypothesis of anti-inflammatory effect directly or indirectly, anti-edema, hyperemic effect, the stimulation of nerve and the progenitor cell regeneration, which mediate this. But on 35 persons which work, only 2 persons have the welding of the lesion. All the other persons continue to have the lesion. So why this? Perhaps for the formation of bypass around the lesion, perhaps for the transformation of glial tissue in functional nerve tissue. I don't know. The stimulation of the cell function, I already said, and all this effect can be interviewed together. At the molecular level and cell level is very interesting. The hypothesis already said yesterday is the mitochondrial activity produced at first water. Is exclusive activity of the mitochondria. One molecule of water is necessary to start all the other activity of the cells of the mitochondria, so production of ATP, etc., etc., etc. When a cell is damaged, the cell don't produce normal water, but peroxide of hydrogen. Why this? Why? Because this peroxide of hydrogen give reactive oxygen species. This is similar than the housewife which clean the room. The cytoplasm of the cell is cleaned. The cell come back versus its function. But when the cell is very damaged, what is the danger? The danger is that the cell with a damage very high can transform it in cancer cell. So the nature give a mechanism, 2 oxygen ions are coupled in singlet oxygen. The singlet oxygen coagulate the cell and the cell kill. So it's not possible the transformation. A laser and light could increase or decrease all these processes depending by the dosage. Another idea is 60 years ago. Can laser ray influence the proliferation, maturation, activity of stem cells? Our data is yes, it's possible. This is the growth factor, one of growth factor, produced natural by cells without add growth factor in culture cell. Another very interesting mechanism of laser effect is the mechanism energetic. 7,000 years before Christ, the men know that the energy around the men existed and were called prana, and the interchange zone of the energy between the men and the external energy was called chakra. in India, Chi and Yang and in the meridian system. And one scientist, White, signaled 97 different names in 97 different cultures to show the same thing. In 20 centuries, the prana is called cosmic energy. We continue at the last century to call chakra the windows of interchange, and aura the energy around the body. Today, the cosmic energy is called quantum energy by Gary Lamb, Nobel Prize, and we have Ilyushin Chekurov, which studied very much this and called the coherence domain the chakras, and bioplasma, the aura, the energy around the body. The role of laser and light therapy can be to influence human energy field, to influence also the bioplasma, which is demonstrated. Bioplasma is composed by energy from 300 until 2000 nanometers. And perhaps light therapy can influence both. You know very well, Netter, the atlas of anatomy. This is the body nervous system anatomy, but we have also the body energy anatomy. And on the right, you can see my energy. My energy 20 years ago. Today is very less. Now it's very less. This measuration is a measuration performed not in India, performed in Orlando, Florida, in the United States. Kirlian effect. What is the Kirlian effect? Kirlian effect is the amount of energy, light energy, around the body. The physics say this energy is composed by the transpiration energy, which in contact with the air give reaction, give light. So light of different wavelengths is concentrated in 7 different layers called auras around the body, linked by it through chakras or domain of coherence. Russian State University of Moscow studied this, and they isolated 3 of these 7 coherence domain, where the exchange of energy is maximum. Energy, light energy, electromagnetic energy, electric energy, not only light energy. Each wavelength seems corresponding with a body system organ. This is, I don't know if demonstrated this is at this moment. It seems that an organic disease could change the features of corresponding aura about 1 month before the start of disease. If this hypothesis will be demonstrated, this is a very good instrumentation to follow the diseases, all the therapies, also the efficacy of all the therapies. It seems that laser and light radiation modifies selectivity the auras. Today it's possible to measure only some features of each aura, and in fact this measure have true limitations, because this measure require the total dark and require the absence of gravity force to avoid the difference of intensity of tone, etc., etc. Perhaps in the future, laser and light radiation could be used as prevention and the therapy of many diseases. Is philosophy? No, because in science, Clark demonstrated the Kirlian effect, or electrical potential effect on the flower with the chakra, with all the life present and exchange of energy between the body in life and between the external. Conclusion. Surgical laser therapy of traumatic spinal cord injuries gives positive results using more wavelengths contemporaneously. These are the wavelengths, and these results could be measured with more systems and tools associated with synergic effect. I can show only some example. For instance, this woman, lesion T8, initially Asia A, 1 year after treatment, 100 sessions in total. Another. This is Asia B. This deambulator is mechanic, not electric.
Sono 32 secondi, va bene?
This is a very interesting patient because he had lesion T10, 11, Asia A. He have only the left arm, and he had also the baclofen permanent pump. And we removed this pump after 76 irradiation and assisted the walk after 18 irradiation. This is the last example of another patient. T8 Asia A lesion occurred 7 years before. This patient, middle age, had total flabby paraplegia. But this patient lost about 1 year because another very important person in Italy said it's not possible that you stand up, it's not possible that you walk. So this don't want to prescribe the tutors. And the paralysis, flabby, transformed at first in spastic with spasms but not contractures. And the spasms were changed for, not for improvement, for poor result of laser. In opposite, when this patient stand up, immediately the contraction, the muscle tone come back totally normal. And this is a book of my personal friend, Ted Mayman. I always remember him because 16 colleagues had Nobel Prize for the applications of laser, but Ted Mayman, no, he created laser. And the motto of Professor Moscati from Italy is very nice for my opinion, is love the truth and work hard to affirm that. I finish with another very good scientist, Einstein. He said that as the paraplegic patient, as the brain traumatic injury patients, is similar than a hornet. And the wing of the hornet has a small size with respect to his body. So he cannot fly for the science. But the hornet ignores that, so it flies the same. Thank you very much for your attention. I wait the hall at the next Laser Florence.
Thank you, sir. Very excellent talk. Sir, you use the 10 watt or 30 watt laser in your treatment protocols. You use the 10 watt or 30 watt lasers in your treatment protocols.
I use all the lasers in that protocols, but attention, the numeric value of the protocols are only an average. And I start with diode lasers. The power of diode laser is 10 watt, but I use on the tissue milliwatts, not watt. You understand?
How much you use?
Use about 100 milliwatts on the tissue, 150 milliwatts, but I use sometimes more power for less time until to arrive at the joule indicated 12 for anti-inflammatory goals and 4 for regenerative goal.
But you have not mentioned for that power for the lesser durations. You have not mentioned the maximum power for the lesser durations, which we have used.
I don't understand what.
As you told that you use the maximum power for the shorter duration to achieve the power.
Yes, I use 2 different power for change the power, and not only the power, to change the power, the frequency, and the spot size, depending what kind of patient I have, depending what kind of lesion I have, etc., etc. And I use more wavelengths, and one wavelength only as target on the colon. The other wavelength is CO2 10,600 nanometer, and the neodymium only on the arms, on the legs, and the diodes around the lesion, and also on the coherence domain. You understand? And I choose the total fluence step by step on each patient. You understand?
You use the laser, it is a single diode laser or multiple diode laser? You are using the laser, it is a single diode user or multiple diode user?
It's not a low level. This is not low level lasers.
It's
non-surgical.
Single diode laser or multiple diode laser?
No, single, always single, yes.
Single diode laser?
Always diode laser single, but with a spot size very large.
Okay.
You understand?
Thank you.
So I'm just curious, Leonardo, why the men could not get control of their bladders, but the women could, but the men could get sexual activity. I mean, it doesn't seem to make much sense to me, but I'm not, maybe Juanita knows because she's an anatomist, but...
Yeah. You touch a pen of my experimentation, because when I must have results of sexual activity of the male, there is the innervation depend by different way respect to the minction. You understand? The minction on the men is the most complicated mechanism, muscular mechanism in the man, because we have about 8 different sphincters, 4 voluntary and 4 involuntary. All these sphincters must open and close, not contemporary, but sequentially, because the urines in the man must arrive down, then curve up, contrary gravity, and then go down. For the contrary gravity curve, we need the pressure, hydraulic pressure caused by about 50 milliliter of urine, but we need also pressure caused by muscles, by these sphincters that must close open to the spinta, the force, you understand? And this is very, very difficult to obtain. In opposite, when we would like to obtain only the sex, the mechanism is totally different. The sphincter are another thing. The sphincter, more of this sphincter are totally closed, blocked. We have only two sphincters, two of very sphincters, and the sperm arrive with a very high pressure, no problem. And the problem is to obtain the erection, but the musculature for the erection is different than the muscle for the minction. And then we have also the problem to coordinate the muscular sensibility with the sensory sensibility. Because, for instance, one of my patients said, I am a very good porno actor because I have erection of 2 or 3 hours. The problem is that I don't have the perception that that is my penis. For this reason, it's totally different, these two functions. One is quite easy, because on the traditional book you can read, it's totally impossible to return at sexual activity after total lesion. It's wrong, because after 13 years of treatment, I never have a problem when the patient follow me. Understand? The minction is my problem. I don't know what I must to change to have the minction.
Okay, I just have one last question. I mean, your results seem very impressive to me. Have you had any interest from other spinal cord injury clinics around the world? I mean, are they kind of asking if they can adopt your techniques? Have any other clinics around the world expressed interest in using your laser technique?
We must, I think that at this moment we have only the first step of this type of treatment, but I think that all us unit the efforts, we can obtain some protocol quite equal in the world. Not totally equal is not possible, because you see, for instance, if I speak about the diabetes, I can use scientific language, I can use epidemiological criteria, I can have some patient with the same answer, etc. With spinal cord, no. This is very difficult to continue without a very good scientific repeatability and with scientific schema. Understand? This is a very one of the problems.
Thank you very much. Let me introduce you to the next speaker of the day, is Dr. Shimon Rochhind. Introducing Shimon. Shimon is an MD and PhD in life science and a professor of neurosurgery. He is a director in the division of peripheral nerve reconstruction and the head of the Institute for Nerve Reconstruction. He has been a reviewer for various scientific and international journals world over, with 70 original papers to his credit, and co-authored 20 chapters of various books. Today, he is going to introduce us into two different topics. One, efficacy of laser phototherapy for peripheral nerve injury and denervated muscle. And the next is neuroconstruction in tissue engineering, the procedure for construction of peripheral nerve and spinal cord. Welcome, Dr. Shah.
Possible to reconnect? It's not connected. Good afternoon, friends, colleagues. Thank you very much, Dr. Mercy and the organized committee for the invitation for this beautiful country, and it's honor for me to be here. Something wrong, it's not connected. You see, color here and color here. The topic of our presentation is efficacy of laser phototherapy for peripheral nerve injury and denervated muscle. First of all, we investigate influence of laser, low power laser on nerve cells. And we found that in a model of microcarriers, after we found that after laser radiation, in nerve cells that are adherent to microcarriers is polysaccharides. After very short period of radiation, 1 minute, 3 minutes, we start migration of nerve cells. I'm sorry, it's something. Migration, no, it's continuing, it's wrong. Direct irradiation of nerve cells shows significant sprouting, axonal sprouting, only in the case of laser irradiation. This slide demonstrates that direct irradiation of nerve cells significantly increase axonal sprouting in irradiated nerve cells. Our model was model of crush injury. It's more typical model and standard model in clinical practice. And this is model is crush injury of the nerve. Results is not complete. Results is incomplete injury. Resulting of crush injury of the nerve start muscle atrophy, and during the time, short period of time, start Wallerian degeneration and increasing growth in new axonal and myelinization. This is spontaneous recovery, but generally it takes time, and in many cases, results is not so good. It was questioned if laser can improve incomplete condition of the injured peripheral nerve. It means increase quality of recovery and decrease time of recovery. This is a crush peripheral nerve in a red sciatic nerve model. It's clear in control group, possible to see is scar tissue formation in area of the crush. Crush was done by standard hemostat, and no scar tissue or significant decreased scar tissue formation in the laser treated group. Also, axonal sprouting was significantly increased in compared with control group. Also, in control group start process of regeneration, but in crush injured group, laser crush injured group, timing of recovery was more quickly. After peripheral nerve injury, always start retrograde degeneration of corresponding segments of the spinal cord. It means destroy of chromatin or myelin. And in the left side is control group, is typical picture of chromatolized motor neurons in the corresponding segments of the spinal cord after peripheral nerve injury, in compared with laser-treated group, where its quality of neurons is much better. The rest was treated finally, this is final results, but we start to treat rest using double treatment. It means directly of injured peripheral nerves subcutaneously and on the corresponding segments of the spinal cord. But patients with peripheral nerve injury also suffered from muscle degeneration. It means muscle atrophy. It was questioned, what influence of laser on denervated muscle or muscle after crush injury? Before this, we investigate what influence of laser on the muscle cells. Laser irradiation of the muscle cells increase significantly DNA synthesis in the mature muscle fibers, and also increase creatine kinase synthesis in muscle fibers. This is cell culture. What practically happened in the rest after crush injury peripheral nerve and triple treatment? It means we treated in 3 points in same time: spinal cord, injury of peripheral nerve, and corresponding muscle. And we found that triple treatment is also involving of involving of corresponding muscle. In this case, was gastrocnemius muscle of the rest, significantly decreased muscle atrophy in compared with control group. This was incomplete injury, because treatment of incomplete injury generally today is physiotherapy, rehabilitation, electrical stimulation. And for me, not only for me, today is growth and growth by understanding that laser can be significant supporting additional treatment in cases of incomplete peripheral nerve injury. It means to significantly support regenerative process into the nerve. What happened in complete peripheral injury? Nerve is completely destroyed. This is example of this ultrasound of one of my patients. You see both nerves after transection, you see hematoma between proximal and distal parts. Or in case of traction injury or compression injury, severe neuroma is like barrier that close nerve, and the nerve results is complete paralysis. In this case, treatment is only surgical procedure. It means removal of neuroma formation, it means scar tissue, and reconnection, it means inter-channel, interfascicular microsurgical reconnection of the injured peripheral nerve. In the last 10 years, increasing more and more, new possibility using biomaterials for nerve reconnection. And today, few kind of tubes for reconnection we start to use in clinical practice. But the principle is the nerve is transected and reconnected by tube from different kind of materials. Our last effort was together with 5 European countries. We received FP7 European Commission grant for biotemplates for peripheral nerve reconstruction. And this was Hitozan. Hitozan is from synthetic chitin, and this tube we start to use for reconnection. First of all, in preclinical proof concept, and this is, you can see example, sciatic nerve of the refs reconnected by Hitozan tube. We also use ultrasound for diagnosis, possible to see tube and in vivo and the growing of the nerve through the tube. And this is final results. We receive full reconnection using Hitozan tube in compare with control group, and also histology was similar. Our question specifically for laser, if also laser can to improve or increase or quality of recovery after tube reconnection. This is same model, and we found that the laser group results is better, is superior in comparison with control group. It means like in crash injury, laser support or increase axonal sprouting and increase myelinization surrounding the axons. Somatosensory also shows a superiority of laser treatment group in nerve tube reconstruction. And histology also use small difference between normal and laser treatment group in compare with control group. Also in control go in regeneration, but laser increase. This is a supporting tool for nerve regeneration. Next point was what happened with muscle. Muscle, complete denervated muscle. I'm neurosurgeon, and everyday practice we operate people, reconstruction, neurosis, and our knowledge is that the best timing for surgery is first 6 months after operation, after injury. Why? Because to prevent or decrease muscle denervation, muscle atrophy. But time to time we operate people also after a long period of time and also have results. This was a work that was a purpose of this work to investigate what happened with creatine kinase activity in acetylcholine receptor in complete denervated muscle. Muscle contraction and relaxation require acetylcholine receptors and action of creatine kinase. Acetylcholine receptor is a synaptic connection, and creatine kinase is enzyme, energetic enzyme for muscle contraction. After complete denervation, significantly decrease acetylcholine receptors and creatine kinase activity during the time. This is example, left side, this patient, one of the patient 2 years after gunshot wound. This is normal leg. This is severe atrophy of the muscle corresponding by peroneal nerve. And this is our model, sciatic nerve injury in the red, normal muscle, and this is denervated muscle with atrophy. In case of complete denervation, in the muscle indeed being totally replaced by scar tissue and of fat, because until now many surgeons have same opinion. We investigate this for a long period of time. Survival time of the rest is 2 years. Rest was operated in age 4 months. It means more than 50% of time rest was denervated, and we investigate what happened. We receive like expected increasing in beginning and decrease acetylcholine receptors, means synaptic activity into amount synapses in the denervated muscle. But after 4 months, we receive peak until 210 days, no change. It means 38% of acetylcholine receptor preserved. This is from nature, from God. Muscle not completely denervated. Something happened, and the plateau is during so long period of time is 38% possible. This gives possibility for new reconnection after nerve reconstruction. Similar picture we receive also with creatine kinase activity. In energetic enzyme, we received significant decreased creatine kinase activity in first months, but until 210 days in same level, 34%. from the normal side. 34% creatine kinase activity and 38% acetylcholine receptors. Maybe it's enough for new reinnervation. This is also a goal, a next step of our study, old denervation, old peripheral nerve injury, and new nerve graft reconstruction. Function of laser in this case is, of course, not so big, but laser have preventive effect. In first period of the denervation, who can stop or decrease muscle atrophy. It means that can also to help for regrowth of the muscle or regrowth of the nerve to the muscle, because we have possibility to receive additional time. For example, this is 18% better in first months with creatine kinase activity. If we summarize this, we suggest the survival of the denervated muscle is longer than previously considered. Laser phototherapy may be effective to preserve the denervated muscle until nerve sprouting into the muscle occurs. And few slides before the end, this is a completely new work we started a couple months ago. It's one of my field, my experience approximately 3,000 microsurgical operation. 30% of this operation is miserable people suffer from neuropathic pain resulting painful neuroma. It's terrible. Most of these people going to receive different kind of narcotics, psychotic disorder. Most of them is young people. The question was possibility to investigate suppressive effect, not stimulating effect, suppressive effect of laser. This is new old our model. We first published this many years ago, but now we modify this model. This model, possibility to investigate laser doses directly on the nerve and receive suppressive effect in a completely independent model without any influence for quality and cleaning of the experience. Rest under anesthesia without curare. Specialists in neurophysiology investigate potential. We investigate compound muscle action potential after direct irradiation on the nerve. This is normal nerve. And we found if you continue treatment, long period of time, this is minutes with huge doses, we receive decrease of the action potential. And after this, we also receive plateau. This is very important. Maybe it's effect for period of time. Suppression effect continues to decrease for a short time after termination of laser treatment. Then reaches plateau with no following change in potential. The results indicate possibility of controlling the nerve activity inhibition. We can calculate doses of the laser specifically so different kind of neurons or different kind of nerves. Similar results we received in rabbits model. This is sciatic nerve of the rabbits, also significant decreases. What important is this? And also we continue to receive functional, motor functional activity of the nerve. What's important of these methods? First of all, this for neuropathic pain is afflicted millions of people worldwide and has been estimated to cure as much as 7% of the population. Many common diseases also a reason of neuropathic pain. But ends of the study, the advantages of the suppressive laser treatment. It means selective block of non-myelinated sensory fibers with preservation of myelinated motor function. It means our goal is to receive suppression of pain with preservation of motor function in patients who have painful traumatic neuroma, especially if involved motor nerves. Thank you very much. In conclusion, phototherapy to his peripheral nerve repair. Extensive review and scientific articles reveal that most experimental study and clinical trial showed laser phototherapy to promote recovery of severely injured peripheral nerve. These studies make it possible to conclude the time for broader clinical trials has come, and this is an extensive review, Honita Anders, Gigo Benato, Rohkind. Thank you very much for your attention.
Thank you, Shimon. You say suppression of myelinated nerves, but the unmyelinated nerves, but they're also very small diameter nerves as well. So they've got two things that make them different. The difference between motor nerves and the pain fibres is not just myelination, it's also diameter of the fibres. Is it possible it's more to do with the size of the fibre rather than myelination? Or do you have evidence that it's something to do with lack of myelination that causes
Yes,
this?
it's possible, because using morphological method for sensitive, nerve is few kind of fibers. Fibers C is sensitive fibers responsible especially for pain. It's also fibers and also in gray in spinal cord in the center. In future we're also going to depress spinal cord of the center of the pain. But if you suppress locally a nerve, you can't differentiate using electrophysiology. It's very clear. What this means? From one side you decrease response, but you have response. Nerve is alive. Second, you have plateau. You can't calculate if you have plateau, and this is what happened after 1 month, 2 months, 3 months. Third, we start to use gold standard model for pain from neuroma. Hunita also doing something similar. It's with suturing of the sciatic nerve, and you have model of a painful neuroma similar like in human being in the animal model. And we investigate this. And of course, after finishing, we will be sent for neuro gastrochemical analysis for sensory. It's only antigen for sensory. You have excellent picture. In my next lecture in spinal cord, I present spinal cord with antigen. It will be possible to differentiate different kind of axons. It's a standard procedure in all kind of institutions. They have laboratory for anatomy and histology.
Have you ever suppressed motor function by over-treating motor nerves? Have you ever been able to suppress motor function with laser temporarily?
Look, first of all, rest after
nerve,
you continue to walk.
Yes.
Look,
Yes.
this
Not
only
that you want to, just accidentally.
It's only starting from the work. We receive first results, objective results, that possible to suppress with measurement nerve function, with preservation of motor function. Next step is how long time it will be preserved, because you have different tests for sensory, the rate test, etc., etc., etc. I believe that enough one or maybe 2 times treatment for painful neuroma, this will be enough, because its treatment is practically, in this moment, we need to open the nerve, because mass energy we lose during penetration through the skin and through the muscle. For this reason, this model for direct irradiation, we use huge doses. Of course, my question is doses 100 more than using for carpal tunnel and Saturday. My question is so many publications and treatment carpal tunnel with this is successful. Maybe it's another mechanism, but laser receive maybe 0.1% from what we use now.
All right.
Very good afternoon, Professor Shaiman. Myself, Dr. Arun Maya from Manipal University. I think my colleague, Dr. John, had met you in Tel University about a month back. Dr. John Solomon, he came for the other collaborative research grant to your university. Recently he met you in Tel University. Can you able to recollect or not able? Okay. Yeah. Sorry, okay. Myself, yeah. Yes. Myself, Professor Arun Maya from Manipal University. About 2 months back, my colleague, Dr. John Solomon, he visited Tel University and I introduced him to you, and thank you very much for good hospitality during his visit. My question is related to the diabetic peripheral neuropathy. It's not directly to your presentation, because we are treating many patients with diabetic peripheral neuropathy with laser therapy.
Today, laser is clear help for diabetic and also for rheumatoid arthritis. Because one of the reasons is, first of all, treatment is superficial, you don't lose energy. And second, especially in diabetic wound, the effect is not on the nerve, in fact it's in the microvascular. Because diabetic wound mechanism is micro. Yes.
Yeah. My question is not the diabetic peripheral neuropathy with ulcer, it's painful diabetic peripheral neuropathy. We irradiate laser therapy local to the foot as well as to the peripheral nerve also we are irradiating. And what we are doing is every alternate day in addition to the measuring the pain scale, we are also assessing the vibration perception threshold. So VPT. The one interesting finding what we observed is there is I just need an answer from you what exactly the scientific basis for that. Like what we are finding, in addition to the decrease in pain, at the same time we are also finding a change in the vibratory perception threshold. So initially the patients present with more than 40, they come with a severe neuropathy, and at the end of 2 weeks of therapy, usually they come back to in the range of 15 to 20. The preliminary report we have published in Laser Therapy Journal about 3 months back. What exactly? Because one reason may be due to the improvement in the microvascular microcirculation. Is there any specific reason by which?
Yeah, it's difference between diabetic neuropathy or any kind of neuropathy. It's practically all nerves is involved, and entrapment local neuropathy is also can happen in the diabetic or something. It's a local problem with any kind of compression of the nerve. In this case, laser can help, but doses must be very significantly more than we use today.
So, Shimon, one thing I'm not clear of, when you get a neuroma on a peripheral nerve, is it both sensory and motor that are involved in the neuromas, that every nerve that's coming down? And also, what are you still using it, 780 that you normally use? What wavelength are you using in these studies?
We use two kinds of wavelengths, 780 and 810. I don't think it's so important wavelengths for painful neuroma. I think important is energy, boost of energy. It's one. Second, neuroma, of course, is formation of, depends what kind of neuroma. Most of neuroma, painful neuroma, is sensory neuroma. This is sural nerve, inguinal nerve, lateral femoral cutaneous nerve. This most of the patients that operate generally. Neuroma of the sciatic nerve or something you treat, we remove, but you don't treat pain, you treat paralysis, meaning doing nerve graft and this. But most of the painful neuroma is the sensory nerve. And treatment is, if medication don't help, is surgical treatment. What kind of surgery treatment? Removal of painful neuroma and implantation nerve into the muscle because nerves continue to grow. Yes.
Excuse me, sir. It was a very nice talk from your side, Shriman, sir. Can I know how exactly lasers can work in demyelinating disease? You have any studies on demyelinating disease?
What disease?
Demyelinating disease.
Demyelinated disease. Yes. Look, demyelinated disease, of course, this is a general disease. Yeah. Theoretically, only theoretically, don't have any experience. It's impossible to help. You can, with laser improve nerve function. But with demyelinated disease, it's impossible to treat all body. You will have any kind of devices. This is problem. Locally, for nerve, laser is good because it increases myelinization.
Yeah.
It's impossible locally, of course. A treatment is maybe future technological solution, but practically it's not.
Mm-hmm. Okay, thank you, sir.
Thank you very much.
ಕ್ಲೋಸ್ ಮಾಡ ಅಲ್ಲ ನನ್ನ ಕಾಣಿಸಲ್ಲ ಅದೇ. Thank you so much, Dr. Shimon, for such an informative session. Switching to the next session, we all know that any form of therapy has to be supported by various forms of nutrition, both micro and macro. Today, we have here an eminent doctor of medicine, Dr. M.A. Chandrasekhar, who is professor in PES Medical College, Kuppam, Andhra Pradesh. He also has a postgraduate degree in diabetology and preventive cardiology. Today, he is here with us to impose on the need of dietary and nutritional requirements in any therapy. Welcome to the dais, sir.
Am I audible? Am I audible? Yes. Right. At the outset, I would like to thank Dr. Srinivas Murthy, Dr. Nayana for having invited me to speak on nutrition in chronic lifestyle disorders. As all of you know, the chronic lifestyle disorders are increasing like anything: diabetes, hypertension, ischemic heart disease. Everything is increasing, arthritis. What's happening? We doctors, we don't tell why. Patient also will not ask why. Simply we give treatment. Patient also concentrates on the treatment. So first treatment what we have to give for the patient is we have to explain why he has got the problem in his own language without using much medical terms. I think if you do that, most of our problems will be solved. So we should tell him why he has got that. So this is regarding diabetes. See, India is becoming the capital of the diabetes. We are all living surrounding the well. In this well, not only diabetes is there, hypertension, ischemic heart disease, obesity, dyslipidemia, cancer, everything is there. Well is there, we are going and falling into the well. The people who are inside, they are crying. The children are standing near the well when I should fall. Some people are, right now 1 out of 5 is diabetic. By 2030, they are telling alternate person in India will become diabetic. So, what are the main reasons? Bad food, wherever, however, whatever we are eating, without knowing what are these, we are just taking and paying the penalty. Second is decreased fiber. Third is decreased physical exercise and more stress and strain. As all of you know, if you get tensed up, the amount of steroid hormone, the amount of catecholamines we secrete, they are opposite to insulin. They will make us to become diabetic. They help in progression of the atherosclerosis, and we are paying the penalty. We always think, see, everything is coming down, walking, everything, sedentary lifestyle is coming. We always think of what we should eat. That's what we are doing. Now, if you go to the diet, our food, we are supposed to eat in a balanced diet. Unfortunately, we are eating something excess, something deficient. This excess and deficiency is producing all these lifestyle disorders. Excess deficiency will produce diabetes, obesity, dyslipidemia, hypertension, ischemic heart disease. I'll give you a good example. We are supposed to eat about 2,200 calories, but without our knowledge, we are eating something around 4,000 calories. Whatever extra we eat, it gets deposited. See, instead of 2,000 calories, if we eat, it's getting deposited. All of us, we are putting on weight. God has fixed for this particular height, this particular weight. For example, 70 kg, he says, I will give you insulin for 100 years. But unfortunately, most of us, we are becoming obese. Once you are 80 or 90 kgs, when God says, I will not give insulin for that particular weight, we are going to develop diabetes. For 80 or 90 kgs, heart has made an agreement, I will pump for 100 years. But if he says, I will not pump, that day diabetes, that day hypertension, ischemic heart disease, infertility, everything is starting. So the obesity, right? So this is balance, this one. Now, let us see what food contains. All of us, we had the lunch in the afternoon. What food contains? Whether it is gobi manchuri, mushroom manchuri, dosa, idli, vada, whatever it may be. Chicken biryani, vegetable biryani. God has given only 7 things in the food. The carbohydrate, the fat, the protein, vitamins, minerals, fiber and water. Extra we add biocontaminants, fertilizers, pesticides, coloring agents, everything we add and we eat. With what intention God has given this food? Let us take carbohydrate. What is carbohydrate? In simple common man's patient's language, carbohydrate is called as sugar. There are 2 types of sugar. Visible sugar, invisible sugar. Visible sugar, what we see from our eyes. What is not visible in the sugar cane or in the carrot or in the maize, we make it visible. Invisible sugar is present in all the food we eat. Rice, ragi, wheat, maize, right? Even anything, banana, mango, whatever, even green chili contains sugar. Bitter gourd contains sugar. So the message is, you cannot get sugar-free diet. Every food what God has given has got sugar. The percentage may vary. Next is fat. What is fat? In common man terms, we say oil. There are 2 types of oil. Visible oil, invisible oil. Visible oil will not fall from the sky into our plate. What is not visible, we make it visible. See, can you see the oil in the milk? We make ghee and butter. Can you see the oil in groundnut? Groundnut oil. Can you see the oil in olive seeds? Olive oil. So, what is not visible, we make it visible. Invisible oil is present in all the food, cereals, pulses, vegetables, even mango contains oil, banana also contains oil. So, you cannot get oil-free diet. Let us think, why we put oil? Majority of our patients say it is for the taste. So, what I say, oil will never give taste. See, if you drink 1 cup of oil, is it tasty? Anybody? If you drink 1 cup of oil directly, is it tasty? No. See, if you are eating buttermilk rice, if you add salt, it becomes tasty. If you add pickle, it becomes tasty. If you put 1 cup of oil, it will not become tasty. Right? If you prepare a green chili, if you keep it in the mouth, it is not tasty. Only if you chew, it becomes tasty. See, for the idli or the dosa or the chapati or the roti, if you have forgotten to put the salt, it will not be tasty. For the sambar, what we prepare in our house, if you forget to put salt, it is not tasty. So, the oil will not give tasty. But we Indians, we are under the impression oil gives more taste. There are 4 or 5 chemicals in our food. When it falls on our tongue, it gives tasty. One is simple carbohydrate. Your sucrose, your fructose, your glucose, it makes you sweet. The papaverine, it makes you salt. The citric acid says it is sour taste. So, some particular chemicals, when it falls on the tongue, it is. So, the oil will not give a taste. But Indians, we are very fond of how much oil we should eat. For 1 person, we recommend for 1 month, half a liter. But if you go to a party and come, the amount of oil we eat, it is more than half a liter. So, why we should add oil? What oil contains? Oil contains 3 acids. One is saturated fatty acid, monounsaturated fatty acid, polyunsaturated fatty acid. A mixture of this acid is called oil. Which oil is good for health? Any oil which becomes solid at room temperature, it is not good for health. Any oil which is liquid at room temperature, it is good for health. Why? Any oil which becomes solid at room temperature is rich in saturated fatty acid. If the saturated fatty acid goes more inside, it will stimulate your liver to produce more cholesterol. So let us educate the patient what is cholesterol. Most of the people are under the impression cholesterol is very bad for our health. But we should tell the patient cholesterol, without cholesterol our brain will not function. Cholesterol is a precursor for our sex hormones, steroid hormones, vitamin D. So cholesterol is very, very important. Without cholesterol we cannot survive. We should tell the patient there are two types of cholesterol, outside cholesterol, inside cholesterol. Outside cholesterol is available only in animal food. Plant food doesn't contain cholesterol. We should tell him. Sunflower oil, in the bottle they put cholesterol free. What he puts, God only has not given. Because sunflower oil comes from a plant source. Only animal food gives cholesterol. Animal food doesn't contain fiber, but plant food contains fiber. So, then another cholesterol is inside cholesterol. The major organ in your body which synthesizes cholesterol all the 24 hours is liver. If you stimulate the liver to produce more cholesterol, your cholesterol level will increase. 1. Doing less exercise. 2. Stressful conditions. 3. Smoking. 4. Taking alcohol. 5th is if you take more saturated fatty acid. Your liver will synthesize more cholesterol. I'll give you a good example. Right side you take ghee. Ghee comes from animal source. It is solid room temperature. It contains saturated fatty acid as well as cholesterol. If you take ghee, you are taking both cholesterol as well as saturated fatty acid. Left side you take palmolene oil. Palmolene oil comes from the plant source. It doesn't contain cholesterol but is rich in saturated fatty acid. When you take more, your liver will synthesize more cholesterol. You know, majority of the junk foods, your gobi manchuri, mushroom manchuri, in the hotel, they prepare the junk food with your chicken beyond, so many things they prepare with palmolene oil. That's the reason even pure vegetarians sometimes will have more cholesterol level in your blood. Third is protein. Protein is the second best nutrient for our body after water. Protein is the only nutrient which builds up muscle mass. Protein is the only nutrient. See, when we were young, we used biological value. Now the recent classification is protein digestibility coefficient by amino acid score. So that is a class 1 score. 1 is soya protein. Second is whey protein, what is present on the water of the curds. People throw the water and drink curds. You should not throw the water which is on the superficial of the curds. Third is egg white, not yellow color. Fourth is milk casein protein. If you take this protein, what will happen? The muscle mass is good. If the muscle mass is good, BMR is good. If the BMR is good, it drinks, in common man terms, the glucose, it drinks free fatty acid, your cholesterol level, your hypertension, everything will come down. So that is the reason building of the muscle mass is an excellent treatment for your arthritis, because it keeps the bone, prevents osteoporosis. Osteoarthritis will come down if you build up the muscle mass. It is an excellent friend for diabetes. Muscle mass is an excellent friend for hypertension and your heart, because it drinks your cholesterol, it drinks your glucose, it drinks, that's the reason building of the muscle mass. The regular protein what we take, beef, out of 100 only 92% will come and sit. Chicken out of 100 only 65. Fish out of 100 only 82. The pulses and all what vegetarians eat, it's only 42%, remaining 58% is a waste. And another important thing, when you are hungry, biochemically, scientifically, nutritionally, our hunger center in the brainstem is asking for protein. Unfortunately, when body is asking protein, we take lot of carbohydrate. When body is asking petrol, we put carbohydrate. We Indians eat lot of carbohydrate. This carbohydrate is killing it is the one which is causing lot of this lifestyle disorders. So taking protein when you are hungry, that is what the body is asking. So why we are not healthy? See, poor eating habits, sedentary lifestyle, excessive drugs and medicines, and pollution which you can't avoid. So this is the one which is producing this. So instead of putting food versus nutrition, all nutrition is food, but all food is not nutrition. So nutrition is what our body needs on a daily basis to stay healthy. So how much carbohydrate and fat and protein should be there in a balanced diet? Carbohydrate should be 55 to 60%, fat should be 25 to 30%, protein should be 10 to 15%. But of late our diet, carbohydrate is 80 to 90%. Do you know the food what we ate in the afternoon, which is rich in carbohydrate? The carbohydrate rich, this one, refined wheat flour, polished rice, maida, hotel food, marriage food, junk food, all are very rich in carbohydrate. If you eat more than 60% carbohydrate, that carbohydrate gets converted into fat. First in the blood, next in the body as fat. That is when people say, I'm a pure vegetarian, sir. Why have become diabetic? What I tell is, if you want to become a diabetic by next month, if you want to get hypertension by next month, don't do anything. Take simple polished rice. Morning this much, afternoon this much, night this much. Don't add even sambar also. Next month you will become diabetic. Children, you give them 1 or 2 months only junk food. Next month they will become diabetic. Pediatric diabetes is increasing like anything in India. So for the penalty, instead of putting petrol, what I say, our vehicle is a petrol vehicle. We have to put all the 24 hours petrol only. Our engine is suited for petrol. If you put diesel or kerosene, our engine will get spoiled. Same thing is happening. Instead of putting petrol, if you put diesel and kerosene to your engine, so this is the penalty we are paying. See, all, starting from constipation, faster aging, right, diabetes, obesity, ischemic heart disease, stroke, everything, osteoporosis, arthritis, everything is increasing. All are directly or indirectly related to the food what we are taking. So this is an excellent slide. Compare our ancestors. Compare our this one. In the olden days, they were living long. They were living long, dying short. If the person lives for 80 years, 79 years healthy, 1 year struggling. Now people are living for 80 years. But 25 to 30 years, living short, in another 50 years, taking tablets, this amount of file, this amount of tablets. This is what is happening nowadays with the life. So this is an excellent slide. So we should tell the patient to get this type of life, not this type of life. This is also an excellent slide. In the olden days, food was grown. See the tomato seed. Tomato needs 3 months to grow. Nowadays in 15 days they make like this. It looks very big, but nutritionally it is not good. So a lot of unethical practices to improve the color, to improve this one. So we are eating lot of pesticides, fertilizers, all those things we are eating. So this is another good slide. See, if the fat content in your body is more, 1 kg of fat needs 500 miles of vasculature. Imagine the amount of peripheral resistance on the heart. If the fat content is more, the heart has to work too much. That is the reason it will be put under stress. So getting this muscle mass, this is the correct treatment to prevent arthritis, to prevent hypertension, ischemic heart disease, diabetes. So that can happen only with class 1 protein. So this Linus Pauling has told, if humans get pure water, 29% oxygen and 46 essential nutrients, our cells will be healthy. Are we getting it? Are we getting it? No. See, we are not getting. Are we getting the essential nutrients from the food we eat? We ate food in the afternoon. How much protein, how much calcium, how much vitamins, we don't know. We have taken. So, that is the reason, the penalty. So this is the doctor. If the doctor... So this is the penalty for all, this one, see, the toxic colons, if you take all size of toxins. See, imagine, the length of the tongue. Your GIT is 7 times your height. To satisfy the tongue, we are destroying or damaging the whole of our GIT. See the length of the tongue. See the length of the GIT. 1, 2, 3, 4, 5, 6, 7. 7 times our GIT is there. So we are not paying much importance. Wherever, whatever. What our tongue says yes, our body says no. What our tongue says no, body says yes. This is a good slide. We should tell the patient, this 99 grams is mainly rich in carbohydrate and fat. 1 gram contains all proteins, vitamins, minerals and all those things. This is very important. Without this, we are going to die. But without this, we can survive. So this we have to educate him. This is how we are eating, wherever, however, whatever. So what's happening? What's happening with this type of eating? The whole India is becoming obese. Obesity in our country is also increasing like anything. So if you are overweight by even 10 kg with muscle mass, no problem. If you are overweight with fat tissue, we are going to pay the penalty. So this is what's happening to our country nowadays, off late with this one. So prevention is better. We should be like this. We should not go to the ICU and keep like this. This type of life nobody wants. So diabetes, ischemic heart disease, everything is increasing. So we have to find some solution for all these things. This is an excellent slide. Why we should eat food? Why? Why we should eat food? The common man will tell so many things. He doesn't know. He says, I'm getting bored, I'm seeing the TV, my friend invited me. So many things he will tell. We should tell the patient in his own language why we should eat food. First reason is for energy. This mainly comes from carbohydrate and fat. And the most important thing is repair. Repair of our this one. See, the skin will fall off. Why skin should get repaired? Why nail should grow? Why hair should grow? Suppose if you take the bone marrow produce RBC, all of you know the lifespan of RBC is 3 months. It comes here in the reticuloendothelial system, it gets killed. It happens. Suppose if you don't take food for 2 months, your hemoglobin will come to 2 grams. So for production of hemoglobin, what you need? You need vitamin B12, folic acid, iron, protein. If you don't take, that is a repair work. If you don't take, so food is the one which supplies all these things. When diet is wrong, medicine is of no use. When diet is correct, medicine is of no need. So what is good health? A good understanding between the organs inside the body is called good health in common man terms. So the basic structure of our body, all of us we talk about mitochondria, ATP, everything. If this cell is happy, tissue is happy, organ is happy, system is happy, the whole body is happy. So the nutrition is very, very important. But unfortunately, this is a healthy cell which is working nicely. If the cell becomes unhealthy, without nutrition, you will get all sorts of diseases. This I have already told you. This is an excellent slide. When we get up early in the morning, our body demands 46 nutrition. See, this is the food what we eat. Everything is there. Whatever your biryani, your dosa, your everything is there. If you think of invisible sugar in this, we are really astonished. We are concentrating only on visible sugar. The invisible sugar in this type of food is too much. See, masala dosa, 71.7%. The chutney may be spicy, all this one may be, the mouth become maybe this one, right? People take 3 masala dosa and take sugarless coffee. I don't know whether to cry or laugh. This is what is happening. We are not worried about invisible sugar. Visible sugar, I want sugarless coffee. Less coffee, less coffee. We should tell the patient even plain milk contains sugar. So the chapati 66.5, idli 90.1%, this one right, upama this one right, jamun 87 point, plain rice 93.3%, especially polished rice. If you take polished rice, glycemic index is more. Your rapidity with which the blood sugar goes to your, this one is more. So this is what happens. Your body needs about 120 calories per hour. People they don't take good food in the morning, good food in the afternoon. They come in the night, they say, I have not taken good food in the morning, good food in the afternoon. It's my right to eat. They'll sit in front of the TV in the night, dhan, they will eat and they'll sleep off. People who eat more in the night, they'll become diabetic. People who eat more in the night, they'll become obese. That is proved, scientifically proved. This is an excellent slide. What is fat burning zone? What is fat creating zone? See, you have taken breakfast. How to explain the patient is a good slide to explain the patient why you will become obese. See, he has taken idli in the morning, blood sugar increases, so it's immediately the green color, insulin also will come to make the sugar to go inside, glucose to go. So insulin will do the job, will make all the glucose to go inside. See what happens when you take food? Insulin will show glucose 3 places: your brain, your muscle, your heart, your liver. It shows extra glucose. Insulin says there is no space in the brain, no space in the liver, no space in the muscle. Extra space is fat. The glucose will go inside and get converted into free fatty acid inside the. So excess calories is stored as fat. So next what happens? Next what happens? Again you will eat. Again you will eat. So the falling insulin again will rise. So what will happen now? Again same thing happens. You are still in the fat creating zone. So what happens? So what is the message is? What is the message? You are not allowing the pancreas to take rest. So you will always have hyperinsulinemia. So this will not come to the basal level. So you will be always in the fat creating zone. So what happens now to your body? What happens? External obesity and then internal obesity, and then so scientists find how obesity may lead to diabetes. So your insulin resistance is more. Insulin says I can't work. If the muscle mass is more, it goes easily inside. Basal metabolic rate is more. So if the fat tissue is more, you are more prone for diabetes, hypertension, ischemic heart disease. So this will produce what? You will become obese. His brother type 2 diabetes, his brother hypertension, his brother ischemic heart disease. They are all interrelated. So the muscle mass is very important. One thing I would like to tell, in your body there is a storage space for carbohydrate in the form of glycogen, muscle glycogen. There is a storage for fat, but there is no storage space for protein in your body. Every day you should take protein, 1 gram per kg, especially class 1 protein. American Heart Association has given a statement. If you take 25 grams of class 1 protein every day, you can prevent so many diseases. Unfortunately, we don't give much importance to class 1 protein. So protein, it is not stored in the body, unlike fat and carbohydrate. This we have to tell the patient. So he has to take protein. Our diet is deficient in protein every day, about by 25 to 30 grams. You calculate your protein intake every day. You are deficit by about 25 to 30 grams every day. But it is rich in carbohydrate, rich in fat. So taking class 1 protein is very, very important. Dr. Louis Signaro, who has got a Nobel Prize. See, all of you know L-arginine. L-arginine, the pharma companies, they come and give the prescription or this one. L-arginine is the raw material for the nitric oxide production. If the nitric oxide production is good in your heart, you will not get ischemic heart disease, erectile dysfunction, your Viagra functions are the same. So nitric oxide production, the raw material is L-arginine, comes from class 1 protein. So the protein content of various our Indian common foods, but we are deficit, less than 25% we are not taking. So let the food be the medicine, not medicine be this one, right? So nutrition helps in anti-aging. I can't postpone your age, but I can postpone your aging with food. So infertility, all these things we know, we should tell the patient in his language only. This I have already told you. So for every 5 kg excess fat, peripheral resistance is more. Heart has to pump 1440 liters. How long heart will work? One fine day he says no. Ischemic heart disease, hypertension, everything will start. So this is the problem with the fat. So diabetes in coronary artery disease 23%, coronary artery disease in diabetic 85%, American Heart Association scientific statement. So the 2 major killers in our body, diabetes, uncontrolled diabetes and lipids, dyslipidemia. So 1 hour walking will produce You are spending about 300 calories, but eating one jamun, 300 calories. How many jamun will you eat? How much we are going to spend? We are not spending only. So we are just storing in a fat creating zone. So food pyramid is textbook description. Nowadays it is reverse. That's the reason we are paying penalty. Our food pyramid is becoming reverse. So with an excess of fat, diabetes begins. From an excess of fat, diabetes dies. So the second most important thing is fiber. Fiber is a boon what God has given in our food. Fiber is called as unavailable carbohydrate. Fiber is called as, there are two types of fiber, soluble fiber, insoluble fiber. We are supposed to eat 30 to 40 grams of fiber every day. But unfortunately the fiber content is coming down. For everything we want polished rice. For palau we want sona masuri. For biryani we want basmati rice. More polish you give, fiber is thrown out. When you are young, you used to take wheat to the floor. Nowadays nobody wants to take wheat to the floor. Everyone wants soft chapati. They will see the TV this much size and they get the chapati. Outer layer of the wheat is fiber. Outer layer of the rice is fiber. If you take the anatomy of the wheat, anatomy of the rice, God has kept fiber, vitamins, proteins outside. In the center part of the wheat and the rice, God has kept the sugar. We take only the sugar. We throw everything out. Fiber, vitamins, minerals, we throw it out and we eat only sugar. That's the reason we are paying the penalty. So when there is less fiber, what happens now? There is rapid absorption of oil and sugar into your blood. Insulin, God has to give insulin immediately. God has told you to use the pancreas for 100 years. If you go to a party and come, the amount of oil and sugar you eat, it has to do 10 days work in one day. It says, I will not do, that the diabetes starts. When I was doing MBBS in 1980 in Bangalore Medical College, only minister used to get, the professor used to tell, hey, diabetes. We used to see through the window, we used to see, oh, diabetes, I saw diabetes, we used to clap. Now, everyone is becoming diabetic, sir. Software engineer is becoming diabetic, fruit vendor is becoming diabetic, everyone is becoming diabetic. So we have to find solutions. We have to tell the patients, not only rich people, even poor people are also becoming diabetic. So the pancreas says, I will not do. So that day, diabetes starts. Software engineers, everyone in our country, even poor man is becoming diabetic. A person who sells the vegetables, who sells the fruits, they are becoming diabetic. It's a very pathetic situation. A person who sells gobi manchuri, 21 years, he says, I have become diabetic. Why? After the business is over, whatever is left, I will eat. That's the reason. See, we should tell the patient why you have become diabetic. So this genetic background, we are genetically predisposed. So now our Indians are becoming, my father and mother are diabetic, this one is diabetic, I will also become diabetic, my children also. One thing is definite, genetically we are predisposed. We can definitely postpone the diabetes. Instead of becoming diabetic at 30 years, if you look after your pancreas nicely, you can become diabetic at 70 years. That definitely can be done if you follow the dietetic habits. So this is a very good slide. You should tell the patient in this way. To start with, hypertension, diabetes for 7 to 8 years or 10 years, it will not do anything. What I tell the patient is, till 90% of the coronary artery is blocked, no complaints. Is asymptomatic. It takes years together, but 10% blockage takes in seconds. At that time he will come with ischemic heart attack. So we have to do bypass, we have to do so many things we have to do. At that time only patient will come. Similarly, paralysis. Till 90% get blocked, he will not come. After complete the blockage, he comes with hemiplegia like this. Another thing I would like to tell, dialysis is becoming very common nowadays. Till 70% of the kidney is damaged, urine output is good. Patient is not bothered. Anyway, I am passing good amount of urine. Why I should come? Why I should visit the doctor? So I have made compulsory for all the patients to get microalbuminuria. If you do microalbuminuria, if you recognize microalbuminuria much earlier, definitely you can postpone the complication of the chronic kidney disease. But unfortunately that is not happening. After the complete this one, patients are coming. Same thing is happening with diabetic retinopathy. Same thing is happening with amputation. People come after the gangrene has developed. So you should tell the patient about the education of the foot, education of this one, how to this one. So what we have to tell, it takes 7 to 8 years to develop the complications, microangiopathy or macroangiopathy. You should educate him and you should give, definitely you can postpone these complications. So this is a very good slide, pre-diabetic. I think in India we can get about 50 to 55 crores of pre-diabetic patients. How to recognize pre-diabetic? See, pancreas is just like a car. Car has got the diesel, reserve tank. When the car is running out of reserve, you will not have any problem. But if you don't take care, car will stop. Same principle, when pancreas is running under reserve, sugar is normal. Father and mother are diabetic. Children will get the blood sugar done. Fasting 90, postprandial 120. He says, I am not diabetic. Get his lipid levels done. If there is a dyslipidemia with normal sugar, he is a pre-diabetic. If he has got IFG, impaired fasting glucose, or if he has got impaired glucose tolerance, and another is GDM. GDM is becoming very common. Once the baby is delivered, GDM will disappear. Patients are very happy, but again it will come back. So these are the people where we have to recognize, we have to tell them one thing. They should reduce their fat mass. If their fat mass comes down by 5 kg or 10 kg, insulin resistance will come down. Their pancreas from reserve tank will become full tank. The scientific method of losing weight, everyone says you do dieting. You do eat fruits and vegetables and go to naturopathy or something. If you do dieting for 1 month, what will happen? You will have hypoglycemia. You know the only source of energy for brain is glucose. Brain says, I will not work. Then the muscle says, I will help you. Muscle will get converted into energy to supply your body needs. So after 1 month, you lose 5 kg. Whom you lost? You lost your friend. Your enemy is here only. So what you should do, take class 1 protein, then you do dieting. Now if there is hypoglycemia, body says, I want energy. The first source of energy, muscle says, I will not get converted. The second source of energy is fat. Fat will be, you will go to a condition what is known as fat burning zone. If you are in fat burning zone, even when you are sleeping, the free fatty acid will come out from the adipose tissue and you will start losing weight. This is the correct scientific method of losing weight. So education is most important. The most important treatment for diabetes or arthritis or whatever ischemic heart disease or hypertension is education, then our treatment. But unfortunately, we are not giving much importance. We are also busy. Patient also says, give some treatment. Most important and neglected mode of therapy. So you should always tell in everyday language. We should not use complicated medical terms for the patient. Now, how to improve the new fiber content? See, many people say, I eat lot of fruits and vegetables. See, if you take the content of the carrot, 80 to 90% of the carrot is water. 80 to 85% of the radish is water. So, the fruits and vegetables, if you want to get 30 to 40 grams of fiber, you have to eat this much every day. We should tell the patient the major source of fiber is your cereals and pulses and dal. Pulses and oil seeds. They are the major sources for fiber. Now, fruits and vegetables will not give you this amount of fiber. So, most of the fibers from our cereals and pulses, we are throwing it out. So, if you take good amount of fiber, it prevents rapid absorption of oil and sugar, and the pancreas will start laughing. Another important advantage of increased fiber is you will never get acid peptic disease. Third, it binds all the bile acid in the intestine. Bile acid is thrown out. The raw material for the bile acid for the liver to synthesize your bad cholesterol, LDL. Without your knowledge, LDL will come down and you will never get constipation in your lifetime. If you relieve the constipation of the patient, he says, you are my God. So constipation is also becoming more common, right? So this is if you take the anatomy of the wheat, the outer layer is fiber, inner layer is refined wheat flour, this is sugar. This only we are eating. We are throwing out all this one. See, excellent source of insoluble fiber, dietary fiber. So unpolished rice, nowadays we are using even millets. Nowadays all those things we use, that also gives a good response. So this mixture, 1 kg of wheat, 200 grams of soya, 200 grams of green gram, and 25 grams of methi gives a good response for response for diabetes. It's a rich source of this one. So what to reduce the obesity, we should reduce 99 grams. To decrease the cholesterol level, we should reduce 99 grams. If you do dieting, both 1 gram also will not be available, 99 grams also. So dieting is not the solution for diabetes. You should not fast, you should not feast in diabetes cases. This I don't think we need this one. So these are the goals of diabetes, and if everything fails, God only should save. And this is an excellent slide. A statement of truth. A person asked God, what surprised you most about mankind? God replied, they lose their health to make wealth, and then lose that wealth to restore their health. By thinking anxiously about future, they forget their present, such that they live neither for the present nor for the future. They live as if they will never die, and they die as if they have never lived. This is what is happening to our day-to-day life. So, if you give proper education to the patient regarding his nutrition, daily intake of the food, I think we can do wonders for the patient. So with this nutrition, laser therapy will be more effective, stem cell therapy will be more effective. So we should give more education to the patient in his own language, which first it is ridiculed, then it is violently opposed, finally it is accepted as being self-evident. So that is the reason what I do in the hospital, I take classes. I give TV programs, I give so many this one to educate the people. Thank you very much. I think I've gone a little bit fast. If there's any doubt, you can ask me. Yes, sir.
So you said about taking fiber when you're having oily foods.
Pardon me?
You said about the importance of eating fiber when you're having oily foods.
See, the one thing is,
Can you just explain the difference between soluble fibers and insoluble fibers,
right,
and which are the ones we should be using?
See, there are two types of fiber, insoluble and soluble fiber. Soluble fiber are hemicellulose, cellulose and pectin. This one. Insoluble fiber, your gaur, your pectin, your mucilage. See, this insoluble fiber, your GIT cannot do anything. Your hydrochloric acid in your stomach, it cannot break down. So it's called as unavailable carbohydrate. If you take today, tomorrow it has to come out in your stool. That is what God has told. So this insoluble fiber, soluble fiber, both should be there in your diet. Suppose if you are eating oily food, nowadays wheat bran is available. It's available throughout the world. If you make it like a pour it and drink, then if you eat oily food, it will not get rapidly absorbed. That's the reason fiber is giving wonderful response in managing your diabetes, constipation, ischemic heart disease and hypertension. So the outer layer of the cereals, outer layer of the pulses, that is very rich in, God has kept fiber there. That we should know.
So salad isn't enough just because that's all soluble fibers. To have whole grains are the thing that give us the insoluble fibers.
So that's insoluble fiber. Soluble fiber, you see, it prevents the absorption of this one. They have found out in soluble fiber will reduce your dyslipidemia also. Your cholesterol levels also will get this. It comes in the way of your absorption of your fat and all those things.
Thank you.
What would you advise the poorest of the poor about nutrition? And yes, I'm talking. You cannot hear that? Hello? What would you advise the poorest of the poor about nutrition?
See what is available in his home, this one only we see the protein, the cheapest protein for him is egg white, not yellow color. We'll ask him to take egg white and this good amount of pulses, good amount of dal, that I'll advise. But sometimes nowadays, there are so many soya proteins also available, not very costly. Soya isolate, soya concentrate, so many are available, about 300 or 400 rupees per month. It's a good method of this one, giving him good amount of protein. Probably if you educate the patient, we can do so many things for the patient. Thank you very much. Thank you.
Yes, Dr. Chandrasekhar, that was a lot of nutrition. How about a tea break now?
No.
Thank you. A quick tea break of 10 minutes before we start with Praveen Arani again for the next session. Only 10 minutes, please. Welcome back. Total 8. No. Yeah, so let's start the next session for the day. After this last power pack session on nutrition, let's invite Praveen Arani again on Precision Photomedicine Part 2, where he's going to be talking about photobiomodulation and stem cells for tissue regeneration. Welcome, Dr. Praveen.
That's not my presentation. Okay, great, thanks. All right, I'd like to thank again Dr. Murthy for inviting us and organizing this meeting. This is going to be part 2 of my presentation, so I'll start with a very brief recap of what I spoke before. These are my disclosures. These are the companies that support some of our research. I'm currently an employee of the SUNY Buffalo, State University of New York, Buffalo. And I'm also the current president of the North American Association for Photobiomodulation Therapy. All right, so what I wanted to do was start very briefly with a quick recap of yesterday, like I said. And we talked about photobiomodulation. We would like all of you to use that term, better than low-level light, because it's very difficult to explain to a scientific audience what low means and what level refers to. So photobiomodulation nicely encompasses the scientific rationale of what we are trying to do. And remember, and this is the definition that has been indexed by the National Library of Medicine as a medical subject head term, a mesh term. And the definition that they have used is the use of non-ionizing source of photonic energy that generates non-thermal therapeutic effects. And like we talked about yesterday, there's a much more elaborate definition that we in the field think is more appropriate. That also encompasses different sources of photonic energy, LEDs, broadband light, as well as lasers. We like to call it photobiomodulation because, as people have emphasized for the last 2 days, it can promote positive processes as well as inhibit certain negative processes. Positive processes such as if you want to promote wound healing or tissue regeneration, or stimulate the immune system for a beneficial effect. At the same time, inhibit deleterious processes such as pain or inflammation or an aberrant immune response. You heard from, this is a slide from Dr. Hamblin, where there are many randomized clinical trials. James Carroll also mentioned that. There's a lot of evidence for what light can do in many human diseases. And the field is moving towards a pharmaceutical paradigm for use of light. A term, photoceutical, has been often used. And again, we use a lot of wavelengths that are also popular for surgical photodynamic therapy as well as UV phototherapy. The difference is that we use very low doses of light. Many people are trying to standardize various aspects of this treatment, both clinically and in the lab. And these are a couple of slides that I shared with you yesterday, where we are looking very carefully at developing robust, reproducible, and rigorous clinical and molecular biomarkers. I talked about how we were able to show surface temperature is a great way of ensuring there is no thermal effect, as the definition tells you. And the temperature we are trying to avoid going above is 42 to 45 degrees. I also showed you some very brief data about molecular markers, if you have access to tissue collection as well as molecular analysis. ATF4 seems to define the light-mediated toxicity. We also understand a lot. I think many people have spoken about different mechanisms of how this treatment works. It is not just waving a light. We actually understand many of the processes, molecular and cellular, that contribute to the therapeutic effect. And we think of them primarily, basically as either primary responses, where light is changing a biological molecule or a target. And then there are secondary responses that we are harnessing by this process, where there is a therapeutic benefit, whether it's wound healing, whether it's reduction of pain, resolution of inflammation. The one mechanism that my whole story builds on is this growth factor. I talked about it briefly yesterday. The growth factor is called transforming growth factor beta 1, and it's normally secreted as a latent complex, which means it's present all over your body. Every cell makes it, but it is kept inactive by the presence of that blue peptide, the latency-associated peptide, that keeps the dimer, which is the red peptide, red part of that complex, from binding its receptor. So what we need to do physiologically is to remove that latency-associated peptide, and we can do that by various physical and chemical means. We have shown, as I showed you yesterday, that you can do that with laser light, because laser as well as LEDs are able to generate a very active, short-lived chemical species, reactive oxygen species, that in turn is sensed by the latent growth factor itself, and this causes a change in the conformation and activates it. This is very similar, to draw an analogy, to what happens in the eye when visible light hits rhodopsin. There's a change in the conformation and the protein is able to initiate biological signaling. So with that, I'll end with the last slide of my recap, where we seem to have uncovered one of the mechanisms of how light therapy works in the right context. And this specific mechanism has broad implications in many human diseases where TGF-beta is very important, as well as given the role of TGF-beta in immunomodulation and stem cells, which I'm going to talk to you today, where it has a key role in driving differentiation and maintaining pluripotency. And I think I mentioned this again yesterday. We are trying to do precision-based medicine here. So we want to build from mechanisms, molecular mechanisms, to convert what we observe in the clinic. All of you are laser practitioners, or most of you are. And you have seen that you're getting benefit. But if we understand the mechanisms, we can make this mainstream clinical practice. It can become standard of care. So I've divided my talk into two parts, where I'll talk briefly about how TGF-beta activated by light can be used to direct stem cell differentiation. And then I'll talk to you about some of the newer work that we are doing with combining lights and biomaterials. So I'm trained as a dentist, and I think I've been inspired by dental problems as a major focus of my career. And the premise of using dental stem cells comes from the fact that we have adult resident stem cells in our teeth throughout our life. A stem cell has all the information that every other cell in your body has. The only reason that it can become a differentiated tissue is based on the fact that it expresses certain genes. Now, gene expression for muscle, such as actin, will result in its contractile function, while the same genome, when turned on at the right place to express hemoglobin in a red blood cell, an erythrocyte, will enable the cell to carry oxygen. Similarly, in the case of dentine, which is most of my story at the end of this part, needs a very specific matrix protein, dentine silyl-phosphoprotein, to give it its character. Sorry? He's arriving in 10 minutes? Okay. All right, so our chief guest is arriving in another 10 minutes, so he might be interrupted in the middle. All right, so when we think about stem cells and tissue regeneration, we think about many, many things, and we usually think about the controversies with embryonic stem cells. But I think the point that I like to emphasize, and many of you in the audience are familiar with this, is that besides embryonic stem cells, all of us have resident, normally present stem cells in almost every niche in our body, whether it's the bone, whether it's the skin, whether it's the muscle or the brain. What we need to be able to understand is how do we use these, and these are also present in the teeth, as shown on this. The question is, how do we talk to these cells to promote their regenerative effects? And this is not new, because when you have injury and you have tissue repair, you have these cells differentiating and producing a very specific tissue. So if you could understand the language, and I think I'll come back to this point in the end, in which we can speak to these cells, we can promote their behavior as well as their function. So turns out that this growth factor that we are working with, transforming growth factor beta, is not only a central player in stem cells from various niches, it's also very important for dentine formation, because dentine is a structure in the teeth that is responsible for maintaining viability. Why would you want to make dentine? If you go to a dentist and have deep caries lesion, tooth decay, our options are either to place a medicament or a cap, like we call it, with a cement called calcium hydroxide or mineral trioxide, and then put a filling on to prevent the need for a root canal. If the inflammation and the infection has reached the pulp, then we are forced to remove all the structures inside the pulp and do a root canal. Now, that is great because you're preserving the tooth anatomy in the mouth. Nonetheless, you have removed the viable part of the teeth, which makes it more susceptible to breakage. So having a crown and a root canal is not ideal. If you could figure out a way of making dentine with lasers or any other technique, we could prevent the need for a root canal and thereby maintain a normal viable tooth in the mouth. So this is one reason why we would want to use a potential laser TGF-beta dentine forming technique. The other reason we would want to use this is as all of us age, our gums recede, and then you get something called tooth sensitivity. You are sensitive to hot and cold stimulus or foods. And to prevent this pain, you are basically prescribed a toothpaste or a medicament that you are on a lifetime supply of. Well, how this paste works is basically you have these tubules in your dentine which are responsible for the pain. And these toothpaste basically block these extrinsic openings by depositing heavy salts. So instead of doing that, if you could do laser treatments, we could potentially overcome this sensitivity by plugging the dentinal tubules from the inside. And that's a picture here showing you that this treatment could potentially get rid of, a one-time treatment could get rid of tooth sensitivity. So to do these experiments, I'll show you some in vivo data, and then I'll jump in one in vivo data and then jump into in vivo studies, in vitro, and then show you in vivo. We basically took dental stem cells from human patients. These are either first premolars that come to us for orthodontic extractions or third molars, wisdom teeth. We take these cells and analyze them for certain cell surface markers. Those colored outlines of cells are meant to represent a stem-like state. When you treat them with lasers, we hope that they would differentiate into odontoblasts, which would lay down specific matrix, which then undergoes mineralization. So this is how we would like to do the experiments. So this is the data where we actually remove the cells from human subjects, human teeth, and looked at certain markers. These are cell surface markers that tell us that we have actually collected dental stem cells. When you remove cells from an in vivo scenario inside your teeth and put them on plastic dish, the first thing we want to do is make sure that they would respond to any kind of treatment. This is immunostaining. You can see those red dots here that represent a complex that is present in your cytoplasm. When you do laser treatment or add recombinant exogenous TGF-beta, these complexes will go into the nucleus, telling us that these cells will respond to either laser treatment or TGF-beta. So we did laser treatment on these cells and waited for 7 days and found that the stem cell surface markers are down-regulated, which means that the stem cell has differentiated. As a positive control in these experiments, we also add exogenous TGF-beta, which we know is downstream of the laser treatment. And that does the same thing in a more robust manner. At the same time, if you look at odontoblast markers, which is the cell we are trying to make, you find that these markers, ALP, alkaline phosphatase, dentine matrix protein, dentine sialoprotein, and osteopontin, are all upregulated, showing us that we have moved the cells from a stem-like state to a differentiated odontoblast state. Now, having made this tissue, we did a bunch of biochemical and molecular experiments, but I'll take you straight to the in vivo data. What we wanted to do was an in vivo model before we go to human clinical trials. And to do that, we basically did experiments in rats and mice. What we were doing, and I'll show you the model in a second, is either make a defect in the teeth, exposing the dental pulp cells, and then put a filling on top, which is our control group. In the other set, on the opposite side, we would either do laser treatment or put any one of these medicaments, either calcium hydroxide, dical, or TGF-beta with microspheres, or the inhibitor for TGF-beta. We would then wait for 1 week to look at differentiation from the stem cell state, which we have noticed in vitro. And then we have to wait longer to look for mineral deposits. In rats, this is 12 weeks, and in mice, in rats, it is 8 weeks. It's 12 weeks, and mice, it's 8 weeks. So this is the model where we were exposing the tooth by drilling a hole, exposing the pulp, which is the niche. And then we would do our treatments and then place a filling. And then we would wait for different amounts of time to look for stem cell or mineral deposits. So when we take out teeth from these animals and look for stem cell markers, we find that the laser treatment is able to down-regulate the stem-like markers in concordance with what we were observing in vitro. So they are moving away from a stem-like state. We also looked at deposition of the mineral osteodentine, tertiary dentine, and we used high-resolution micro-CT to look for induction of this material within the teeth. As you can see in this, I'm sorry, my labels are not coming up, but the control teeth have some amount of reparative dentine, but in all of the laser-treated teeth, you have a lot more. This result was also validated by histology, so you can make section. That was micro-CT. This is histology, where you take out the teeth and section them and stain them with various stains. And as you can see, even if you instrument the teeth, and any dentist in the audience will tell you this, you get some amount of reparative dentine, which is shown here. But when you do the laser treatment, you get a lot more of this reparative tissue. And as you can see, there's another staining here showing you the same increase in osteodentine. Now, because stem cells are capable of making many kinds of mineralized tissue, the first question would be, is it making bone or other dental tissues such as cementum, enamel, instead of dentine? Dentine, like I said, is characterized by a specific matrix protein as well as calcium content. And this has been well worked out. There's an organic composition as well as inorganic content of hydroxyapatite. So to call it dentine, we needed to establish that the newly formed tissue had a specific composition. And to do that, we used our histological sections and performed Raman spectroscopy, as well as FTIR and EDS, emission desorption spectroscopy. The idea there was to find the calcium phosphate content as well as the organic matrix. And this matched really well with the normally present dentine. Can you see this? This is the normally present dentine. Can't see my arrow. It's that orange structure right next to the normal structure, and those new globs are the newly formed tissue. So the composition of this newly formed tissue was very close to what we would call dentine, and therefore it's called osteodentine. To validate this again in the most robust manner, we used various chemical biology approaches where we are neutralizing TGF-beta with either a small molecule or a small molecule inhibitor or a neutralizing antibody. But I'd like to show you some of the more elegant and more sophisticated work where we're doing transgenic mice. So the same model was generated in a set of mice, and this is considered the absolute proof of the role of this molecule in a biological system. So this was our hypothesis, that laser-generated ROS, which activated TGF-beta and performed the stem cell differentiation. To prove this conclusively, what we needed to do was remove TGF-beta from this system. And to do that, we generated 3 mice. And again, just to give you a very brief background about how these mice were created and why they were created, we know that every gene in our body every cell in our body has a specific gene expression which gives rise to a specific tissue. The dentine-forming cells can be tagged in the body by tagging dentine silyl-phosphoprotein, or DSPP. So the first mouse that we made, we basically put a tag on all the DSPP expressing cells called CRE. So this mouse has all the dentine-forming cells, which are odontoblasts and dental stem cells, tagged with this enzyme called CRE. Next, we looked at the receptor for TGF-beta, and this is a complicated diagram, but what we basically did is, you remember ligand receptor binding in your biochemical classes. All we did was we tagged the receptor with another tag called LOX. The LOX expressing TGF-beta receptor is present in every cell in the body. When we mate these two mice, the DSPP CRE with the TGF-beta R2 flox, we generate a new mouse, which is a conditional knockout. And what it basically is contains all DSPP expressing cells with the receptor for TGF-beta knocked out. This is a conditional knockout. This system was very critical for our validation of our hypothesis, because if you were to treat this mouse with lasers and activate TGF-beta, the TGF-beta would not be allowed to work because the receptor is missing. So we took these conditional knockout mice and first removed stem cells from their teeth and looked for responsiveness to TGF-beta. And as you can see, the red bar there, when you add TGF-beta to these cells, they do not mineralize, which is measured by alkaline phosphatase. But other cells in the body, the osteoblasts and chondroblasts and other mineralized tissue, amyloblasts, are still capable of responding to BMP, which does not act through the same receptor. So we basically drilled holes in these animals and did the laser treatment and found that they do not respond to laser-induced dentine formation, proving that TGF-beta activated via laser-generated ROS is necessary for this reparative process. So with that in mind, we were able to generate what we would call a scar tissue, osteodentine. The ideal endpoint for any regenerative process is pristine, normally functional morphological tissue. To get to that endpoint, we've been looking at using a combination of biomaterials and light. And I'd like to show you some of the work that we're doing in that space. So in terms of tissue engineering, our approach to this problem is there are certain simple pivotal cues that can act as a domino. A very important morphogen or a biomolecule can initiate many downstream processes, and this is what we would call the domino model. But there are more complex stem cell differentiation steps that require both soluble and insoluble cues. And this would be our switchboard model, and we know this is true for many specific stem cell differentiation processes. So to make these dishes, we've been using a combination of scaffolds and artificially engineered morphogen fields. Now, morphogen fields are growth factor fields that drive a certain process. But as every soluble cue, if you put a molecule in a solution, it will go everywhere. It diffuses everywhere. So we have come up with a way, which I'll show you in a second, combining molecules with their inhibitors to create very specific fields. And to do this process, we are using many different biomaterial techniques. I'm going to talk to you today only about gas foaming, which is one of the processes. So we take basically resorbable suture material, PLG, polylactic glycolic acid, and combine that with either salt or sugar crystals that we have milled to a particular size. We mix this and put it under pressure, CO2, carbon dioxide, for 16 hours, which foams, melts the polymer and makes them go all around the sugar or the salt molecule. Then we drop this whole scaffold into water, and the salt or sugar leaches out. This creates that nanoporous, macroporous or nanoporous structure, which is what we use for our stem cell niche. These scaffolds can be seeded with various cells, as shown here, and they can be promoted along a specific lineage of differentiation. So this is an example of your porous scaffold, and with a combination of both an inducer and an inhibitor, we are able to create very sharp fields of morphogens to drive cellular differentiation. Just to show you one of those models, we have created different fields within the same scaffold that is seeded uniformly with mesenchymal stem cells. And when we do that, and we are creating these morphogen fields by using these microspheres that we generate with the same material, the PLG scaffold material. This is a regular slow delivery or sustained delivery system where the molecule, in this case a growth factor or a small molecule, can be controlled in terms of its presentation to a cell. And you can do a slow, sustained control release. So we have used this. I'll show you two examples of where we have used this. The first case is where we have used TGF-beta to induce a specific field that can drive either dentine or cartilage induction, while we're using BMP, bone morphogenetic protein, to drive a bone-like phenotype. So when we design these controlled release systems, we first do simulations in COMSOL, and this is just a computer simulation where we are showing that you can create a BMP field, a bone field at one end, and a cartilage or a dentine field at the other end. To validate these systems, we put reporter lines, which are basically gene reporters that will tell you that this growth factor is active, and they are tagged to luciferase, which emits light. You can see that as predicted, there will be an area on one side where you have TJ beta, which is a chondrogenic or a dentinogenic field, and at the other end you have a BMP or a bone-forming field. And as a control, again, we put both the reporters in the same scaffold to show us that we have two distinct fields. So having validated that we can make such a system, we began to look at where we would want to use it. And the first problem that we addressed was in this circular core and shell scaffold, where one scaffold had TJ beta and the other one had its inhibitor. These scaffolds have been seeded with mesenchymal stem cells all through, bone marrow-derived mesenchymal stem cells. And this is just a picture of cells lining the whole scaffold pore. So in this scaffold system, we have put latent TJ beta in the center, and we put the inhibitor all around it. And we know that light can activate this growth factor. So when you don't treat them with light, you have this amount of luciferase activity. But when you activate it or treat it with light, you get a robust induction of the signaling within the scaffold. And remember, all the cells are the same throughout this field. So we are able to create dentine like a matrix in the basal state, which is right here. But when you do the laser treatment, you can induce this much more robustly. The other place we have used these scaffold systems is trying to make cartilage and bone, which would be very helpful in, we heard many of the osteoarthritis and rheumatoid arthritis, where the joint needs more cartilage and bone to restore normal function. To do these, the core and shell model would not work, so we actually went ahead and used the layered models that I told you about. Instead of using, these were the other supplements. In case of dentine, we were using TJ beta and a low density of mesenchymal stem cells, while for the cartilage, we used a very high density and other supplements as noted here. So we use the same scaffold system, but with other factors inside the scaffold to drive a differentiated fate. We also know that cartilage is hypoxic, right? So instead of making the whole scaffold the same porosity, we actually milled smaller particles and created a nanoporous part of the scaffold as well as a macroporous part of the scaffold. And this is just a picture showing you the interface between the macroporous and the nanoporous part. When we put MSCs throughout this scaffold, we can induce an hypoxic response, as noted by HIF1 alpha, indicating that you have this area that is more avascular in nature. And along with TJ beta 3 and the other factors, we were able to show that both the matrix COL2 as well as transcriptional activation of cartilaginous genes is seen in the cartilage field, which is the TJ beta 3 field on your left, and the bone field, BSP1 and osteopontin are seen in the bone field on your right. You can obviously differentiate them with other biochemical stains as shown here, with allicin blue on one side and alizarin red for bone. And you can do even more sophisticated analysis for calcium depositions. So I hope I've shown you that light can do a lot of things by itself, but in combination with certain biomaterials, it can even do much more precision-based treatments. And I showed this yesterday as well. There is a special issue coming out on photobiomodulation and stem cells, highlighting the amount of progress we have made in understanding where we are in this field. And I hope all of you get a chance to see this. This will come out in November of this year. So all of that work was obviously done by a huge group of people. This is my team. My mentors on the right, David Mooney is my tissue engineering biomaterials mentor. Mike Hamlin, who's here, was instrumental in many of the laser studies that we did at Wellman when I was in Boston. Dr. Roberts is the lady who actually discovered TJ beta, and I was fortunate enough to do my postdoctoral training with her. Dr. Kandaya is a professor here in Yashwantpur, Indian Institute of Science, whom I worked with for the TJ beta story. Dr. Nayak and Dr. Kale are my professors in my residency in dental school who encouraged me to start all of this work. My funding is in the bottom. Many collaborators have given many key reagents that have enabled this study. the group in the Mooney lab, the group at NIH, I presented a lot of data yesterday, as well as my current group. I think I have pictures, right? That's my group at NIH, and this is my group currently at Buffalo. And I'll take questions. Dr. Rao?
So you have, thanks Praveen, it was a wonderful talk. So you have all conclusively shown that TGF-beta is causing your differentiation and dentin forming for this thing, right? So what is the advantage of using light over the action molecule?
So you think of any biological and instantly you think of all the barriers for translation. There are regulatory barriers, there are economical barriers, and there is an acceptance barrier by the practitioner. Now, all these are, I think, technically artificial barriers. Every time anyone has ever used a biological molecule in vivo, whether it's BMPs, whether it's KGF, whether it's any of the other PDGF, there has always been documented evidence that it's a go signal, it's an accelerating signal. And that always has resulted in complications, whether it's stenosis of the spine with BMPs or excessive fibrosis and scarring. Using light activates it endogenously. And we have evidence that it also invokes certain autocrine regulation in this process. So anytime you can have the PRP story, right? The patients have a lot of good growth factors in small pockets in the platelets. That seems to work much better than any drug that you throw at it or any biological that you can throw at it. So I guess in this forum it's a more holistic endogenous healing, but there is scientific evidence that it works much better. Sure, you can put TGF-beta in, but that will bring in a lot of regulatory limitations, cost limitations, manufacturing limitations, source limitations. So I think in many ways light treatment, photobiomodulation, is a better way of doing the same thing in a safer and more effective way.
Is it conclusive that whatever is started by the light can be stopped, or is it self-regulated that it will stop at some point in time?
Right, so there is evidence that it is self-correcting in many ways, and like we pointed out in many presentations today, too much of it is bad. But if you do the right amount, you seem to be within a therapeutic window. And there is a way of monitoring that during treatment, like we talked about surface temperature, and there are also molecular markers that will tell you that you're within a therapeutic range. There is no evidence that there is an excessive induction of any kind of cascade that would cause complications as yet. But again, the more people do it, I think the more data we'll get in that aspect. But there is no evidence right now that you would invoke some kind of a pathological cascade with this process.
Right, because you're essentially talking about, you started off with the premise of the domino effect. So there's potentially some cascading that's happening, signal transduction that's happening.
Yeah.
And obviously the initial impulse matters, because if you have the appropriate impulse, then you'll only get the appropriate result.
Right. So I can give you 3 very specific examples from our data. One is ROS. We know ROS is bad, right? We know a lot of processes where ROS can cause cancers, can cause senescence, a lot of damage, redox-mediated diseases. Low amounts of ROS is critical for normal function, and a classic example is nitric oxide. So what we're doing is very low amounts of ROS with this process. The other example is TGF-beta. TGF-beta, when you think about it, it's usually scarring that you associate increased matrix formation. But none of our wounds are healing with scarring. They're healing actually with a very scarless healing pattern. The third example is NF-kappa B, and this was work I did with Mike Hamlin when I was in Boston. We normally think of NF-kappa B as pro-inflammatory, but all our laser treatments are able to induce it robustly within 15 minutes. And we are seeing anti-inflammatory effects. So there is a self-correction here that we truly don't understand yet, but there is no evidence that any of those initiated pathways will go out of control and cause pathology or diseases.
Thanks so much.
Dr. Praveen.
Oh, yeah.
At the beginning of your talk, you mentioned that photobiomodulation also increases the immune system. So can you just very, very briefly narrate a few clinical procedures for it?
So there's a lot of evidence, especially, and you can talk to James, he has a whole cache of papers he can send you right away. There is a lot of evidence that photobiomodulation with the right protocol can reduce pain and inflammation specifically. They have done very well controlled animal models, cell culture models, human studies, and whether it's PGE2, whether they're looking at TNF-alpha, whether they're looking at a cytokine profile, a cellular profile, neutrophils, lymphocytes, mast cells, or just functional recovery from injury. There is a lot of evidence that light at a particular dose works better. I think I was talking to a couple of you. It seems to be that pulse protocols with higher peak intensities are better for pain relief, while in most of our studies we've been using CW at lower irradiances. So think of it as a drug, and think of it as dosing being critical for the biological response you want to initiate, whether it's driving stem cell differentiation, whether you're reducing pain. You just can't take light and use it with a given protocol for all the biological responses.
Oh, and my second question, that I read in a magazine that if you are able to grow 1 mm of cartilage, the company will be bigger than Apple. And in the later part of your talk, you were attempting to do that with light. So how far is that time where you can really get it done and make it available for the clinical use on human patients?
So we are in the process of trying to begin human clinical trials. As you saw, we have a lot of molecular data, we have small animal data, we have tox data, we have biomarkers. We have a lot of scientific evidence that you would want before you do a human clinical trial. So all I can tell you at this point is we are in the process of getting regulatory and funding approvals to begin human clinical trials. I will point out that we are able to make dentine and dentine specifically. You mentioned enamel, and we have not had any success. I don't believe any lab has been successful in trying to make enamel, which would be a gold mine, I guess, commercially and for a dentist practicing. The dentine works because you have dental stem cells. The enamel does not work because we don't have amyloblasts, which are cells that will actually make enamel. They get shed when the tooth comes out in the mouth. But there are people who are trying to do it with other kinds of stem cells.
There is a startup company in Chicago aiming at 2 pharmacological solutions of creating cartilage.
I'm sure you know, there are people who are banking cord blood stem cells, they're banking tooth stem cells, bone marrow stem cells. The field is poised to move forward with regeneration if we can figure out how to make a specific tissue and keep that tissue in its differentiated state. We know that we can make any cell a stem cell by the induced pluripotent story, by transcription factors, small molecules. But to be able to make a differentiated tissue and keep it in a functionally safe way is where we are poised in the whole field, not just in lasers. Lasers is one of the tools, so I wouldn't extrapolate beyond that.
Thank you very much.
I think in the interest of time, we should move on. Okay, James, you can ask.
Well, it depends if we need to stop.
Burning question.
The same question I ask you every year, just in case you have some new information. Do you know the source of that ROS yet? What's the absorbing chromophore?
Well,
what's leading to your ROS?
So one of the things, and this is a technical question for the field, we talk about this almost at every conference. Our growth factor is present exclusively outside the cell. And we heard about cytochrome C oxidase and how it is present inside the mitochondria, inside the cell. Now when light hits cytochrome C oxidase and generates ROS, it will be diffused, but it will immediately react with many other molecules. So the question that James is asking is, what is the source of ROS outside the cell? And I think the best explanation me and Mike have come up with is it is the water. Although now I think the evidence is more towards 980, more near infrared than closer to 810, but nonetheless, there is some absorption.
So that would be the absorbing chromophore, but that's not the source of the ROS then, is it? So what's the cascade following water absorption? What do you think?
So water would be the source. It would generate reactive oxygen species. The oxygen comes from molecular water.
Okay, so it's...
No, it would not. You would not have type 1 and type 2 reactions. Okay, there. He's going to correct me on that. So. You should talk to him.
There's got to be a secondary effect after that. Well,
once you generate the ROS, there are going to be many targets. One of the targets is going to be TGF-beta. We don't think it's the only target.
Yes, it's the bit between the photon, what's absorbing the photon, which could well be water as well as anything else, and then.
Right.
Is it not possible that the intracellular ROS, intramitochondrial ROS,
diffuse out?
Goes extracellular?
Except for peroxide, I think there is no evidence it would, but peroxide could. hydrogen peroxide could go out of the cell. It can actually go paracrine. It can go to different parts of the body. But singlet oxygen, superoxide, hydroxyl radical would immediately react with something in the milieu. But hydrogen peroxide, sure. So that could be one other source.
Well, that would stop me asking the question every year. I'll add it to your list.
Yeah, we'll keep asking and we'll hopefully address it at some point.
Thank you, Praveen. That was an eye-opener. And let me welcome Janice Ailes, who will be giving us a talk on photobiomodulation in eye diseases. Janice is a professor of biomedical sciences at the University of Wisconsin in Milwaukee. She's a PhD in pharmacology and has done extensive research on mitochondrial dysfunction in retinal disease. She has over 20 years of research on light therapy in retinal disease. Welcome, Dr. Janice. Computer.
Otherwise, it's just going to be magic. Thank you.
1 second, ma'am.
Right, thank you. Let's see. There it is. All right. So we're going to take a little switch here, sort of go back to when I came in this morning. Juanita was talking about various and sundry other photoacceptor molecules. I'd like to bring together two areas that are extremely important to me. I've spent most of my academic career studying the role of mitochondrial dysfunction in retinal and neurodegenerative disease, and the last close to 20 years now studying the ability of light, of far red and near infrared light, to modulate and enhance mitochondrial function. And this really goes to several of the topics that we've talked about today. Mitochondrial dysfunction is ubiquitous. It's a big problem in diabetes. It's a problem, as I tell my graduate students, basically what gets us in the end is our mitochondria poop out. We rust and we can't take out the garbage at a cellular level. So what I'd like to do is talk about this work that I started a number of years ago, which I like to call Unblinded by the Light. I'd like to thank the nascent Indian Association for Laser Therapy, Dr. Murthy, the conference sponsors. I'd like to point out the analogy or the connection between, it took me a while when I was thinking about photobiomodulation to sort of pull things together and realize that evolutionarily, chloroplasts, which we widely accept to respond to light stimulation and cause plants to grow, and mitochondria, which are not only the energy elements of our cell, but in essence, essential intracellular communication elements, and really the elements of our cell that I think are our ultimate timekeepers. When our mitochondria start to poop out, we're looking towards the end here. And these guys are evolutionary kissing cousins. They basically moved eons ago into plants as archaebacteria, and into animals as sort of the cousin archaebacteria. And the fact that light stimulates both of these organelles should not come as any surprise to us. And so mitochondria and light are just, they're a natural connection, a natural fix. So going back to Praveen's definition, my definition here, a little simpler, of photobiomodulation is the process by which a chain of biochemical reactions is triggered by light exposure. In order for this to happen, the photons have to be absorbed by a chromophore, a photoacceptor molecule that absorbs light at that wavelength. We understand this in terms of, we accept it in photosynthesis. As a vision scientist, I understand it in terms of phototransduction, vitamin D, but another photoacceptor molecule that's very important is actually the enzyme, the key mitochondrial enzyme, cytochrome C oxidase. And cytochrome oxidase absorbs light in that wavelength and undergoes some form of conformational change. Now, this is the trickiest part so far. We don't know whether we actually push out, we knock a nitric oxide molecule that's been bound to a binding site in there, and then we enhance the activity of the mitochondrial electron transport system, or we cause some sort of redox change and increase the production of a superoxide molecule, which could then be metabolized to hydrogen peroxide and get out and turn on other signaling pathways. We do know that all of this results in secondary signaling, and this has been well documented by the Hamblin Lab and also by Praveen's group. And we know that photobiomodulation improves mitochondrial function and stimulates antioxidant pathways. So why is this important? Well, as I alluded to, mitochondrial dysfunction is absolutely essential. It plays a key, elemental, crucial role in cellular aging and in degenerative diseases. In inherited mitochondrial diseases, which are fairly rare, in aging, which is occurring to all of us, particularly as we've been sitting in this room, we're all going through this process, in degenerative eye diseases, in neurodegenerative diseases, cardiovascular diseases and stroke, metabolic diseases, diabetes. So big, it's a huge target site, and it's a ubiquitous target site. So, as I said, two things I love. I like mitochondria. They're my favorite little subcellular organelle. And my favorite organ in the body is the eye, the retina, photoreceptor cells, which are packed with mitochondria. And I'm very interested in the aging and dysfunction of the retina. So questions that I wanted to ask when I started working on this, I trained as a pharmacologist. My drug is now light. So when I started using light as a therapy for retinal disease, I wanted to look at diseases like retinitis pigmentosa, diabetic retinopathy, age-related macular degeneration. We're looking at major blinding diseases all over the world. So we're looking at these in terms of models. I'll introduce you to the eye here. Here is the a cartoon of the eye. Light comes in and actually goes all the way through the retina. Now, one of the most beautiful things about the retina is how wonderfully organized and relative to other parts of the brain simple it is. You come through the ganglion cell layer, the bipolar cell layer, you get to the photoreceptors. They're actually at the back of the eye because they require a huge amount of oxygen. They're packed with mitochondria. They are the most metabolically active cell of the body. So these cells have to have a huge oxygen supply, which comes from the choroid and the retinal pigment epithelium. Light response triggers and goes back through the optic nerve, through the bipolar cells. It gets modulated here by horizontal and American cells, and then hits the ganglion cells, which form the optic nerve, and it all comes back here, and you can see me. And when this isn't working well, frequently the problem is here with almost all of these diseases, and it has a lot to do with the mitochondria not working well. So I've looked at this, and I'm going to make an argument here that we've shown in several diseases now, in retinitis pigmentosa, some work in macular degeneration, in diabetic retinopathy. I'd like to go, we started some work in an inherited retinal degeneration, Leber's hereditary optic neuropathy, a number of years ago in Brazil. I'd like to go back and work on that more. And these all converge here. So you basically hit this vicious cycle. Mitochondrial dysfunction leads to oxidative damage, leads to mitochondrial dysfunction, and as you gradually spew out more and more reactive oxygen species, you induce cellular dysfunction and death. So if you could stop this in almost any disease state, you could basically ameliorate that disease. Well, we have a great disease to study, actually. Retinitis pigmentosa is a very severe retinal degeneration. It affects 1 in 4,000 individuals. It's a fairly common disease in that sense. It's also one that you can actually reproducibly model in an animal system, which is not nearly as easy, or at least a rodent system, for macular degeneration. So one of the most common causes, which is kind of interesting in that the disease is actually caused by a mutation in another photoacceptor molecule. That key photoacceptor molecule, rhodopsin, the rhodopsin, that absorbs light, undergoes a conformational change, is a single photon acceptor molecule, a very sensitive. We wish we could make things this sensitive. Mother Nature is amazing. But if you screw up and mess up and mutate amino acids, and you can do a lot of different rhodopsin mutations and come up with essentially retinitis pigmentosa, what happens is the rhodopsin, instead of not folding properly and going to the outer segments of the rods and the cones out here where it's supposed to be, it gets stuck in the endoplasmic reticulum of the cell, and it causes what's known as endoplasmic reticulum stress, or ER stress. That generates oxidative stress, and then you start seeing the mitochondrial damage, and you can see the whole cycle moving forward. So we asked the question, actually I should show you what it looks like then. So here is, it's kind of the reverse, or the mirror image of macular degeneration. What happens in macular degeneration is you lose central vision first. You lose your cones. And so essentially what remains in macular degeneration is sort of peripheral vision, but you can't read, you can't see, you can't drive, you don't have acute vision. Retinitis pigmentosa, I guess in some ways, is a little nicer eye disease, if you can say that's possible, in that it starts in the periphery, because that's where we have most of our rods. And what individuals lose first is peripheral vision, night vision, rod vision. And the cones aren't affected until the very end. And we believe that that's because there's just something about losing all the rods that creates a toxic environment for the cones to live in as well. Because the mutation, the toxic impetus for this disease is just in the rods. And what makes this a wonderful model for a bench scientist like me is we have a rat model that's virtually identical, or at least genetically identical, to a human model. So the same mutation, a mutation, proline histidine mutation at position 23, in rhodopsin, a P23H transgenic rat, is the same mutation that occurs in 12% of the individuals with autosomal dominant RP. So it's exactly the same genetic change. And what happens is the rod photoreceptors begin to die early in development, and then death sort of slows into adulthood. Very similar to what happens in people, only on a quicker scale. So in this case, you start out with an abundance of rods when you're just a baby rat. After you open your eyes, you wait just a few weeks here, and depending on how many doses of the mutant gene you have, or how many copies, whether you're line 1, 2, or 3, your photoreceptors start dying off. And we measure that in terms of thickness of the outer nuclear layer being the layer of photoreceptor nuclei. So as this shrinks, your photoreceptors are dying, or the rats are in this case. And what we can do then is follow this. We can ask questions functionally and histologically. So the experimental design was to actually look at the effect of 830 nanometer light. We've done 670, so we've done red, or far red, and we've also looked in the near infrared 830 range. And in these particular experiments, what we did was we treated these animals in what we call a critical period. That period early on where they lose the majority of their photoreceptors between P10 and P25. So about P10, P12, the little guys are just beginning to open their eyes. What we actually do is move mom off to the side, put the lamp right over the entire litter, and treat the entire litter with the light, move mom back, she's just fine. As they get older, we treat them individually, and we treat them until they're, so from postnatal day 10 to postnatal day 25, and if I go back here, you can see that, these are in the area where we're having this very steep range of cell death. And the first thing, so we decided what we would do then was ask a number of questions about treating these animals. We treated them with 25 milliwatts per square centimeter of light, illuminance, for 180 seconds, which gives us a joules or affluence of 4.5 joules per square centimeter. These parameters were determined on the basis of a number of studies in other models of retinal disease and degenerative disease. They seem to fall in the dose arrangements in terms of photobiomodulation, I think, are our biggest challenge. And what we have now is what I like to call a sweet spot. We know that if we're way down here on the dose-response curve, we're not going to get any response at all. But it doesn't just come up like a pharmacologic curve generally and level off. It comes up, it peaks, and it comes back down the other side. And so what we need is to be someplace at the peak of that curve, and we found that somewhere between 5 and 10 joules in our hands for our studies is within that range. And then at P30, we looked at these animals in terms of retinal metabolic state. So we wanted to directly ask the question, how are their little mitochondria doing? Did they get sick with this disease, as has been postulated? And did the light make them better? What happens in terms of retinal function? Well, you cannot get a rat to read an eye chart and tell you how they're seeing. So we actually do electroretinograms where we flash light in their eyes and measure an electrical response. These are the same protocols that are used on people with eye disease. We looked at retinal morphology. We looked at histopathology. So the first thing I want to show you is some work that is our approach for looking at metabolic state. And this was actually done collaboratively with Masa Ranji at the University of Wisconsin-Milwaukee. She is a bioengineer who trained with Britton Chance, who is sort of basically Mr. Mitochondria and near-infrared light, and has developed a technique for looking at redox ratio, which basically is just a measure of the health of the mitochondria. And what we showed with this is that our transgenic animals, shown in the red here, are, are sick. I mean, here's a normal, the normal retina is shown in the blue. So this is a normal redox ratio in terms of mitochondria in retinal tissue. And in the transgenic animals, it's shifted to the left, indicative of a more oxidized and a more dysfunctional state. And in the animals treated from P10 to P25 with the light, it overlaps with the blue. It's actually back to normal, which was remarkable. One, it provides the first evidence in this disease, in a rodent model of this disease, that there's mitochondrial dysfunction, and it also provides convincing evidence that photobiomodulation ameliorates that dysfunction. The next thing we did was we looked at photoreceptor function, and we looked at that by full field flash electroretinography. So to do this, we take our little rats and put them to sleep, put tiny little electrodes on their eyes, slide them into a mini Gansfeld apparatus, big white bowl, where we can flash light at them, and we record a response. The A wave is the photoreceptor response, and the B wave is bipolar cells and Mueller cells, kind of everybody else. This drives this. There's some other waveforms out here, but these are the two that we're most interested in. And what we saw was, if you focus on the blue line here, these are the animals that were not treated with photobiomodulation, that were not light treated. These are normal, healthy, non-mutant animals. Clearly, normal eyes are much better even than PBM-treated eyes or light 830 nanometer light-treated eyes. But there is a significant increase in the amplitude, and what's shown down here on the x-axis is what we do is we just make the flash brighter. It starts out very dim, gets brighter, 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 goes up to a maximum response. Basically, you hardly get any response out of the mutant guys. You get a considerably better and significantly better one out of the animals treated with 830 nanometer light. When you look at the B wave, it's even more obvious that there's an improvement in retinal function. It's still intriguing to me that we don't see as big an improvement in retinal function as we do in mitochondrial function. The next thing we looked at was we worked with Joe Carroll at the Medical College of Wisconsin, and instead of what we wanted to do was be able to do some serial measurements in living animals. So we did spectral domain optic coherence tomography, which is like taking a section, a histologic section of the eye in a living animal, also developed for humans, and in fact then miniaturized again back down so we can do it in mice and rats. And you get marvelous depth perception. It gives you a readout on the health of the retina, and you can actually measure the thickness of these retinal layers, just like you can in a tissue section, except you don't have to kill the animal. So you can measure your animal at day 5, 10, 20, all the way out, which makes for a wonderful continual study. And what we saw was that photobiomodulation protected the retina, assessed by spectral density OCT. Here's the P23H animals without light treatment, and the total retinal thickness is double in the animals with light treatment. And just looking at the thickness of the outer nuclear layer, there are no photoreceptors at the optic nerve, so you count the little guys coming out, or you measure thickness coming out, and there's a significant difference in both the superior and inferior aspects of the retina. So the next thing, and this is really my ultimate objective in research, I want to understand mechanism. I want to see this in the clinic. And so we're beginning to look at studies in macular degeneration and in starting some studies in diabetic retinopathy. And I guess I have to throw in one of my disclosures here. I didn't throw it in at the beginning. I've done some of this work collaboratively with Lumathera. And so this is a clinical study that Lumathera has going, where what they're doing is looking at 3 120-second treatments per week for 3 weeks of essentially a mixture of wavelengths here. There's a far red, there's 670 nanometer, there's an 810 or 790, and then there's a yellow in there. So it's a mixture of different wavelengths. I personally am a big fan of the far red in terms of therapeutic effect, but we're actually testing the efficacy of each wavelength. And the treatment is short and for 3 weeks. And the effect lasts for 6 months to a year, which astounds me. And the outcomes that have been measured are visual acuity, and with people you don't have to do, you can show them an eye chart, and they will read it for you. Contrast sensitivity, and that same measurement I just told you about, spectral density OCT. So to date, and this is some work that Dr. Graham Mary and his colleagues presented at the Vision Research meetings this spring, showing that in 80 eyes so far, and it's an ongoing study in Toronto, that visual acuity change was statistically significant at 3 weeks. These people are seeing better. The difference between being able to walk across your house and not, the difference between being able to drive and not drive. And there's one line on the eye chart, so you see one line smaller for 90%, 50% are 2 lines. There's nothing out there that does this for dry macular degeneration. Wet macular degeneration you can treat with VEGF inhibitors, but basically you're just stopping the bleeding and the neovascularization. And about 10% actually show a 3-line improvement. So there's statistically significant improvement in visual acuity, and also in contrast sensitivity. I'm not showing those data. And the group has just recently started using spectral density OCT, because it's such a beautiful technique, to look at drusen. So what happens in AMD is these nasty little clumps of garbage. Like I said, you get old, the garbage builds up. The stuff that the retinal pigment epithelial cells does in terms of digesting garbage for the eye doesn't do so well, and you get these drusen deposits which start building up, and what they do is they start cutting off the blood flow that's going through the RPE to the photoreceptor cells. So you've got sick retinal pigment epithelial cells, which are the caretakers of the photoreceptor cells, and they can't take care of things they need to. They can't phagocytose the outer segments that they have to do, so they end up spitting out half-digested stuff, which becomes drusen, which clogs up the machinery and creates a barrier for blood flow, and the photoreceptors start to die. And what happens is the drusen starts to go away. It's actually less in, and you'll have to, some of this you can see some of it here. They've got some better pictures coming out now, but it's actually shrinking. And there's a paper that just came out recently showing that in cultured retinal pigment epithelial cells, if you treat them with 670 nanometer light, they phagocytose better, which makes sense to me as a mitochondria person because it's an energy-dependent response and it requires happy mitochondria. So at a molecular basis, we have the beginning of a cure or an amelioration for a significant disease. We just showed in a pilot study that I've been doing at the Medical College of Wisconsin a dramatic or a statistically significant, we've got a small number of patients, improvement in visual acuity and in the decrease in edema, which occurs in diabetic macular edema in patients treated for 4 weeks and then assessed 4 weeks later and 6 months later. And we're continuing those studies as well. So we have really shown that photobiomodulation is effective in animal models of retinal disease, in human clinical trials, and there's more work going on. Dr. Tim Kern is setting up a trial with the National Eye Institute to look at diabetic macular edema. They've actually shown, it's taken a while to catch their interest, but they've shown an interest in doing this. These are the people who do the work. Actually, I would particularly like to thank Sandeep Gopalakrishnan. Sandeep not only was our tour guide for our trip here, he was my most recent PhD graduate student. He's now an assistant professor at the University of Wisconsin-Milwaukee. Heather Schmidt and Betsy Abro, and all the good folks who provided the money. Thank you very much. I'm happy to take questions. Yes. Yes. Sorry. I'll get over here.
The yellow wavelength that Lumitherapy uses is 590.
Right.
And if you look at the absorption spectra for cytochrome C oxidase, it peaks at 590. One of the reasons it's not regularly used is that, yellow doesn't penetrate so well.
Right.
So it's not a popular wavelength. But if you have the wonderful thing about the eye, of course, is it's transparent. It's like a window straight there. You don't have much to go through. So 590 stands a chance of being very useful.
I think the 590 does. There's not a lot of, even in cultured cell work, there's a couple of abstracts that talk about it reducing VEGF.
But in theory, it should be a good choice.
But I think, the thing is that experimentally it works. Basically these studies came out of work, the Toronto and Oak Ridge study that Graham and Robert did, where they essentially had patients who were willing to be treated with a sort of jury-rigged arrangement that had 670 nanometer light, yellow, and a small amount of near-infrared. And it worked beautifully. Why mess with something that works beautifully? We're actually taking a step from the bedside back to the bench to say, okay, so which of these wavelengths is doing this, or all of them, or does it work better as a mix? So we're starting to do the mechanistic studies that have already been demonstrated to work clinically.
Right.
So I had a follow-up question on that. So in the Toronto trial, you showed a 4.5% non-responders. Is that correct?
Pardon?
You showed a non-responders rate of 4.5?
Yeah, there were some non-responders.
And this is as any human clinical trial, that's expected. But what is your strategy? They were blind to start with?
I don't, yeah.
All right.
Mm-hmm. Right.
But in terms of moving ahead,
right.
I know you're doing phase 2.
Well, I think, with any of these, with any therapeutic approach, there's going to be non-responders. And
Right.
when you look at the range of responses, when I look at the range of responses in my animals, who, genetically are a whole lot more similar than you and I, it astounds me. So biological variation is very real, and that certainly applies, from, years and years as a pharmacologist, I can tell you I see the same variation with drugs.
In animals, I was just wondering if you're going to go higher or lower, because we know that lower might be the way to go. I was just wondering which way your animal experiments are going.
I'm sorry?
In terms of dosage for the non-responders, which
Should I go higher?
Or lower? I think that's a question we get asked all the time. So I was trying to
there's actually a really interesting study that just came out of the group in Australia at ANU, showing Christina Walter and her group showing that if they and Ricardo Nottoli was actually the head of the study, but what he showed was if they did light damage in an animal model. So if you take a albino rat, or an albino person for that matter, but an albino rat, and even under normal room light or increased room light, they'll get a phototoxicity. So it's light damage, and it's actually a very nice model of an acute macular degeneration model. And they've been perfecting it for years now, and what they showed was that if they did very severe damage, that a low dose of photobiomodulation would not promote recovery, but if they doubled it, it would. So they're now starting to go back and actually do an entire, maybe we can basically look at the severity of the defect and gauge our dose depending on that. Okay. I think that's probably going to take care of it. Thank you.
Good evening. I'd like to take this opportunity to welcome Sri Ravi Shankar Guruji to this Global Summit on Medical Lasers and Regenerative Medicine. And at the start of the inaugural function, I'd request Dr. Srinivasa Murthy, the chairman of the GSML 2016 and the founder of the Indian Association of Laser Therapy, to come on stage. I now request Dr. Nayana to come in and offer Guruji some fruits. Wait. Yeah. Continuing the session, I would like to invite a few of our esteemed speakers who have come in from across the globe. First, Professor Michael Hamlin, who's the chairperson of the SPI Photonics from Massachusetts, USA. Please. Dr. Vanita Anders is the past president of the North American Association of Laser Therapy and of the ASLMS. Professor Shimon Roshkin from Israel, a specialist in photomedicine and surgery. Mr. Praveen Rani is the president of the North American Association for Laser Therapy. Mr. Michael Weber, president of the ISLA Germany. Dr. Lisa Laxo, the ex-president of the World Association of Laser Therapy from Australia. Mr. James Carroll, the CEO of Thor Lasers, one of the leading laser manufacturers in this world. I now request Dr. Nayana to bring in the lamp, to light the lamp, and announce the conference open. Mobile now. At this juncture, I would request Dr. Srinivasa Murthy, the chairman of the GSLM 2016 and the founder of the Indian Association of Laser Therapy, to give a small brief on this occasion. Mic.
Pujaniya Sri Ravi Shankar Guruji and honorable guests who have come from all over the world. Thank you very much for your patience for this wonderful occasion of inauguration of GSML 2016. It is going to become an historical event in the history of healthcare conferences in India. It is going to usher in a new era in our treatment regimes in the chronic degenerative conditions. I am immensely thankful to all the eminent people who have come from different universities and many countries. Even though some of the people have to leave early because of the yesterday's thing and everything. Thank you very much for all of you being present and to grace this occasion and to seek the blessings of Sri Ravi Shankar Guruji. Thank you.
Now request Professor Michael Hamblin to say a few words.
Should I stand here? Where would you like me? Okay. Well, it's a great honor to welcome Sri here. And funnily enough, I was at your ashram not very long ago. I was very impressed with it, and I learned a bit of meditation. I mean, I was quite amazed. I think the work you've done throughout the world is totally amazing. I mean, I think we're all in awe of that. And I think that what we do here with photobiomodulation is not unconnected to the work you've been doing with meditation and yoga. And I think they could even be synergistic. We spent 2 days here talking about all the wonderful way that photons and light can interact with living things, specifically with human beings, and even more specifically with people who have all kinds of diseases and disorders of both the body and the mind. And I think that light therapy in India is, goes very well with the whole Indian approach to life. Okay? You don't want lots of drugs, you don't want lots of big pharmaceutical companies pushing pills down your throat. And light therapy can do remarkable things for an astonishing array of diseases, which we've been hearing here. And, I think that this global summit on medical lasers in India is just the start of India making a real impression in the world in this area. And perhaps there will be more international conferences and more global summits, and we will keep on moving. So thank you.
Dr. Praveen Arone.
Well, I would like to add the congratulations, extending it. Being of Indian origin, I think we accept light as a part of our life, as a part of our spiritual as well as our daily life. So bringing light therapy to India, kudos to Dr. Murthy and Sri for gracing the event. As Mike pointed out, I think it's a part of the holistic health that we can actually bring to the general population. So on behalf of North American Association of Photobiomodulation Therapy, I congratulate you.
Dr. Michael Weber.
Thank you very much that I can be here with all of you, with all these famous speakers, and with you. It's a great honor for me. And we are working in Germany in this field. Our aim is to bring the light everywhere in the body, let the sunshine in our heart maybe, or maybe our brain. And we have a lot of research about this. And what I would like to do, would like to come back every year, bring new research, bring new clinical results, and spread everything what we are doing in your beautiful country. Thank you very much for your invitation.
Mr. James Carroll.
Thank you. Well, I'm really enjoying my trip to India. India and Great Britain, we have a strong and long-lasting, very powerful relationship as a country. For India, obviously, light is an opportunity, as Michael has said. It's drug-free. People heal themselves with light. It's got a good spiritual connections. Even in Christianity, which is the main religion in Great Britain, there's one of the descriptions where God is described, or Jesus is described as the way, the truth, and the light. It's used in this context. here's a huge country, massive population, English speaking, very easy for people like us to come here, and in fact it's a joy to come here. You may even know that Indian food is the #1 food in England now. So I think we feel very connected here. I'm really enjoying this trip, and we look forward to coming back and doing more and helping the universities here develop this technology and taking it mainstream for the population of India.
Dr. Juanita Anders.
Thank you. As Michael had said, on our second day here, it was made possible to visit Guruji and his ashram. And we were treated with just open arms, and it was a wonderful experience. And we got to visit their hospital, their university, their other schools, and it was absolutely amazing. And then we went on to come to this meeting. And I can tell you from the minute this conference started, it's been really inspiring. It's like when you are involved with the creation of something or the birth of something, and there's an excitement involved. And that's what I have felt at this conference. And the other thing that I think has been absolutely superb is the quality of the attendees, the intelligence of the attendees, the questions you've asked. It's just been amazing. And I think if this represents the start of introduction of light therapy broadly into India, that this is an excellent start. And I hope the next time I get to visit the ashram, that among all of your tools, that we see some light therapy devices. It would be an excellent addition. Thank you.
Dr. Shilan Roshkin.
Thank you very much for unbelievable possibility to be here. I'm very happy first of all to be here. And second, I see very serious and very significant collaboration in future for introducing and developing new methods, especially it's important for Indian population. If, for example, in my field is treatment of injured peripheral nerve, many soldiers, road accident, walk accident, and etc., suffer from this. And laser therapy can significantly to help improve the condition. And I'm very happy that I'm here. And after few talking, after few discussion with people, I believe it's not first time in India. Thank you very much for you.
Dr. Lisa Laxo from Australia.
Thank you, Your Eminence, and to all of the terrific people here. Dr. Murthy in particular, thank you for your invitation to come along. Laser photobiomodulation therapy in combination with a range of new non-pharmacological personalised approaches to medicine promises to be of great potential for supplying solutions to some of the world's greatest health problems and challenges. Colleagues at this summit, and including those from the World Association for Laser Therapy who I represent tonight, and on behalf of the President, Professor Rodrigo, we look forward to joining the best creative and innovative minds in India to spread the word, to develop new knowledges, and most importantly to help the vulnerable and the chronically diseased in our society with the hope for a better tomorrow. So my best to you all, and I look forward to returning to see the progress of photobiomodulation in India. Thank you.
Thank you, friends. I now request Dr. Naina to present Sri Sri Ravishankar Guruji, the souvenir of the GSML, in an electronic form and have it released right away. Thank you. I would now request Sri Ravi Shankar Guruji to say a few words and enlighten us with the fund of knowledge that he can present us. Thank you.
With prayers to Almighty and best wishes to all the eminent speakers here on the dais from around the globe and the chairperson of this summit. You know, there is a saying, you find the right thing at the last place. So, though it has taken so much time for this new technology, therapeutic technology to come to India, it has come, and I think it's a boon to this country. And as doctors from around the globe, with an innovative thinking, non-pharmacological approach to health is very vital. Today, we need to be very open-minded about the systems. The paradigm today doesn't say that, we get stuck in one particular system and say this is the way things work. We will have to keep a very open mind and welcome different systems of medicine, different systems of therapies, and I'm so glad you have started this discussion here. Though we are just late by 1 day and 1 hour, nevertheless we have begun this. As it is in India, it's said for everything there is a right time to come. Though we started very much earlier, now our pilot car and the police and our drivers kept going around this place for about 45 minutes. So we arrived here. When we arrived here, this seems to be the right time to begin something new, to establish, and I'm sure this will grow in leaps and bounds in this country, because India has always welcomed new ideas. From ancient times we have said, no Badra Kratavo into Vishvatomukha. The Rig Veda says the most ancient scripture of the world, of mankind. It says, let noble thoughts, knowledge come to us from all directions. And here we literally see from Australia to Germany to US, the whole world is here on this one platform. And we're all coming together for the betterment of mankind. And anything we know we need to share with others, with everyone around us. I always feel the health of a nation depends on the environment, how the environment is. An unpolluted environment, a society free from violence and stress, body free from disease, breath free from quiver and feverishness, mind free from inhibitions, intellect free from inhibitions, and memory free from trauma, and soul free from sorrow is the birthright of every individual. And this is the aim of any medical system or every medical system. In Ayurveda, it says the chapter in Ayurveda begins with Swasthavrita, means your routine. How you have to align yourself with nature. What you need to eat, when you need to eat, how do you have to respect the rhythms in the world, in the consciousness, in the creation, and from honoring the rhythms of the creation, how you can keep the sanity and sanity in the society. Today what we see everywhere, so much violence. I shouldn't say everywhere, I would say in many places, many parts of the world, violence. And depression has become a common thing in society. I remember when we were children, we had never even heard this word depression. And today, depression is a very big issue. And there are diseases which you cannot really say this is a disease, but it is not the wellness or well-being of a person, individual. So, to promote the well-being of an individual, family, society, we need to have this holistic approach. I'm so glad, as pioneers of this topic, metabolic medicine, nutrition, when you have taken all these things which were once upon a time thought out to be something out there. It's not a natural thing to be doing. The natural thing is you have to get some prick injection or operation. But now we have passed that barrier for health care, moved on to dimensions which are more abstract, yet yields concrete results in our life, which is more scientific, more towards the quantum mechanics, more towards the subtler realities of this universe, and impacting the life in all aspects. And this is really good fortune for the current times. And I once again congratulate all of you. This country has always been open to new ideas, and this is both old and new in some way, we can say. So these ideas are most welcome to implement. I am with you, and we will all together see what we can do, how we can reach as quick as possible, as soon as possible, this thought process and this technology to our population, here in India and elsewhere in the world. Because I have always believed the world is one global family. We are part of one global family. And health, individual health and societal health is of most importance. And spiritual, when you come to spiritual realm, it is always, we always say that it's the spirit which generates, which heals, which sustains, and which produces also. Behind every creativity, there is the spirit. Behind every healing and every transformation, there is spirit. Today, spirit, if you say, people have a different connotation for it. The spiritual wealth that we have said, the Sat Chit Anand, that which is conscious and which is bliss. And bliss being our true nature, we cannot stop till we achieve bliss, and that is the perfect health. So with these few words, I welcome you again and again. I mean, you have put up with all the delays and all that thing. These are some of the things that are inevitable. And I think soon we will get over these hurdles that we face in society as well, when we improve the individual health. I'm very interested to bringing network chiropractic, osteopathy. Some of these medicines are not known. Laser therapies, they are not known much in this country. Similarly, there are marma chikitsa, what we call a Dut Nadi. I don't know whether you are familiar about this. Have you heard about it? I am not sure. In Ayurveda, we have a particular type of diagnosis, pulse diagnosis, in which a person is asked to think about some person. Suppose this patient is somewhere else, he is sick, he is immobile. The patient can send someone as his or her ambassador to the doctor, and the doctor will take his pulse. While he is taking his pulse, the doctor will advise the ambassador to think of the person of whom he or she is going to bring needing the treatment, medicine. So when they think of their diagnosis are even today considered very appropriate. But 95% accuracy comes in that. Suppose someone has some problem and the messenger's pulse can tell the doctor what is wrong with the person. And he gives the medicine. So these are sort of telepathic or telemedicine of ancient days, ancient ages. So we need to document these things, revive, rejuvenate, and marry the old and new. With these few words, I once again congratulate and thank you all for doing such wonderful work for our society. May God bless you.
Thank you. I now request all the directors of the Indian Association for Laser Therapy present here to come over to the stage. Thank you.
Laptop.
Sir.
Hello. After this brief interruption, I request Shimon Rohind to just continue his presentation. Thank you.
Good evening again. It will be short presentation because timing is timing. Just a moment, please. Good evening again. I'm going to present shortly our new development in the field of tissue engineering technology for a reconstruction of the peripheral nerve and spinal cord. Peripheral nerve injury is more than 700,000 people in the United States and Europe suffered from peripheral nerve injury. This is example. It's for shrapnel injury of the peripheral nerve with a complete block of the nerve and the inflammatory reaction, or very small fragment, 1 millimeter fragment, response for this fragment in the nerve, the scar tissue formation, resulting in intractable pain and complete paralysis. A treatment of this patient, conventional treatment, is removal of the injured area and reconnection using autologous nerve graft. Our experience with the patient shows that the graft is in reconnection between proximal and distal parts of the nerve. Clinical results decrease with the length of the graft. If graft between 2 to 5 centimeters, 78% of the patient have partial regain of the function. If they find to 10 centimeters, it's decreased to 62. And if it's more than 10 centimeters, only 25% of the patient after surgery, microsurgical reconstruction, have function. New development in the world is producing of artificial tube from different kind of material for reconnection. This is all kind of tube from most of these companies American, only one is European, Hitozan. And our experiences in all kind of tube was positive, is work. For example, this is polyglycolic acid reconnection, completely new regrowth of the nerve. All this part is new. This is Integral Life Science, this collagen tube for reconnection. It's commercial tubes. And this is tubes that we produce together with our European partners, Hitozan tube from Hitozan, but with artificial chitin. And this tube also work very well. A problem of these tubes, all these tubes, including tubes that we produce, it works only until 2 centimeter distance. Most of the injury, especially severe injury or gunshot wound injury, distance more than 5 centimeters. It means solution is necessary. A solution is innovative guiding regenerative gel for nerve reconstruction following severe nerve injury with massive loss defect. We started this in 2004 in this gel that underwent few generations, but this last edition of the gel is composite gel. It's like a extracellular matrix. It contains laminin synthetic peptide, cross-linking hyaluronic acid, and antioxidant, SOD. Three conglomerates together have synergistic effect. In cell culture, we receive significant sprouting in axons in the cell from nerve cells using implanted into guiding regenerative gel. And in vitro and in vivo study, this is model. I'm sorry. It's not too long. So, I'm sorry, anyone can help me? Okay, it's okay. This is a model of the artificial nerve. This is removal of the segment of sciatic nerve in the rest, reconnected with the tube, and in tube we fill the guiding regenerative gel, and expected slowly growth of the axon, and during the time, and myelinated axon. The model that we preserve, we use distance in the rest between distance 15 millimeter. No possibility to reconnect in red with empty tube more than 7 millimeter. And this is proof concept. We receive new regrowth of the nerve through the tube, similar like immunoautologous nerve. And also histology, we receive a good picture of the axons with fascicles in compared scar tissue in empty tube. This is all this nerve growth alone. All this area was in a tube with guiding regenerative gel, and this after 3 months. Completely regrowth of the nerve. And also proof concept functional 6 months after surgery. This is empty tube completely paralyzes, minimal movement in autologous nerve graft, and regain movement in guiding regenerative gel. Knowledge with guiding regenerative gel, we start to use also for our models in spinal cord. My experience with spinal cord many years. We have different models, and I present only 2 models, last 2 models, and our knowledge. What I was thinking how to develop and improve this model. Spinal cord injury is more than 500,000 people in the world suffered from spinal cord injury, resulting in paralysis, complete paralysis is most of the cases, and leading to social and economical burden on the society. In 2004, we start to use nasal olfactory mucosa from same rats, and this is model. Boys, this is boys. This is laboratory. All surgery was done by microscope, and also in special rooms, sterile rooms, the cells will be produced. This is nasal olfactory mucosa cells from the rats, and during surgical procedure, 4 millimeter segment of the spinal cord was removed. This opening of the area of the thoracic spine, where exposure of the spinal cord. Here this is spinal cord, white color, spinal cord of the rat, and 4 millimeter segment of the spinal cord was removed, resulting is complete paralysis, and no possibility for any kind of reconnection or any kind of axons that preserve. 4 millimeter was removed, and in this area, was implanted nasal olfactory mucosa stem cells with a few models. One of the models was this is culture cells that we use, different kind of nasal olfactory mucosa stem cells. All this was implanted together with a previous generation of the gel. You see, simple, practically simple procedure. This is one model. Second model, implantation, was membrane with inserted in tubular scaffold for implanted into the area. This is membrane with many olfactory cells, colony of olfactory cells. It was covered. Covered by gel also. This is a tube with nanofibers with nasal olfactory mucosa, also was implanted. All these models was investigated. This was back during 5-6 years. Was operated more than 470 rats, and we receive results only in few rats. You will be seeing now one of him. Another rat stay paralyzed. And we analyzed a loss of functional results, but we receive morphological results into the transplanted area. Now we will be seeing this is rat completely removal spinal cord. This is control group. Rat, all rats, this typical picture, complete paralyzed. No movement in the legs. And of course, no somatosensory evoked responses, mean no conductivity through the spinal cord in completely paralyzed rats. This rats with implantation, nasal olfactory mucosa stem cells, and she shows movement in one leg. And also we receive a signal, is spinal cord conductivity. Histology, magnetic resonance imaging shows this is intact spinal cord, this is complete destroy in control group, only scar tissue formation, like accepted after spinal cord injury. And in the nasal olfactory mucosa cells, we receive few cells in one area. This is from one of the successful rats, but most of this also scar. And histology, we receive sprouting, but only in the area of transplantation. It means not penetrated, not to proximal, not to distal parts. Also, morphologically, you see, is closed. This is spinal cord after transplantation, and this before was the area without tissue. But it don't work. What was reason? After analysis of these results and after so many hard work, our decision was the problem is not only regeneration alone. A problem is glial scar, barrier scar. His reason of not penetration, because the spinal cord, proximal distal part is alive. A proximal is barrier. It prevents synaptic connection in spinal cord. For this reason, we developed new antigliotic guiding regenerative gel with different kind of antigliotic agents. We investigate this, first of all in cell culture models, and after this in preclinical trial. This is the example. This is reactive astrocytes, this is normal astrocytes. Reactive astrocytes is gliotic barrier response for spinal cord injury. We have possibility today prevent or significantly decrease 90-95% of this scar. It means to give for the axons penetrate through this area. This is study results. It's our model. Spinal cord, removal 2 mm segments and covering by Dura gel. It's like Dura. In control, group, we don't receive any response, like accepted, no somatosensory work response. But in antigliotic guiding regenerative gel, we receive signal 6 months and 180 days after transplantation. This is functional assessment. Functional assessment is the rest start from 0 to 22. 0 complete paralysis, 22 normal. Practically in almost all rests we receive improvement between 6 to 8. And this is picture complete paralysis in control group and starting of the movement in rest after transplantation. This is control rest. Film it's not so wet. Oh, that's okay. He was paralyzed, and this is rest that you have movements, but film is don't move. Okay, we receive partial movement in rest. And most important picture, this is picture that explains what happened. This is proximal part, lesion part, and distal part. And this is higher magnification. Yellow color, this is neurofilaments. You see proximal and distal part similar, but also in area of the lesion, you see new narrow filament. It means it's penetrates, it grows. And this is cystic formation from the skull. The preliminary result of our study show axonal growth in the lesion area with following appearance of limb movements, pointing towards the efficacy of antigliotic guiding regenerative gel in treatment following spinal cord injury. This may suggest potential provision of new bioengineering technology for treatment of complete spinal cord injury. Thank you very much. Yeah. Okay. After 2 years, the work is going now is very intensively because we receive significant support for the study. In 2 years, it will be for good or for bad a proof of concept about this.
After that, though?
After that long, it will be small clinical trial. Because first of all, we use guiding regenerative gel, no any kind of factors. Because it's problematic. Second, spinal cord injury, if volunteers have interest to be operated and receive something new, it will be accepted. In spinal cord injury, not in peripheral nerve. Peripheral nerve, we finished. We have artificial nerve, and now we also look in possibility for a regulatory process for FDA and for EU, European.
It's brilliant work.
Yeah.
Brilliant work,
Yeah.
Shimon. Well done.
Yes, please.
Suppose some other major nerve is dissected and broken. Will this work the same way as in the spinal cord?
Major nerve?
Any other major nerve is broken in an accident.
Oh, it's all today in 2060. All major nerve, peripheral nerve, possible to reconstruct. And today, patients don't need to be paralyzed because microsurgical reconstruction of the nerve gives possibility to improvement. It's question how many percent is from 30 to 70%. Depend from nerve, depend from distance, depend from quality of the microsurgeon and age of the patient.
And the period of damage and the period of treatment, that duration won't matter? Or will is it of concern?
For peripheral nerve injury, very important timing. From injury until timing of surgery. But also damage. Most of the nerve, if it's local damage, also if distance 5, 10 centimeters, possible receive improvement. Problem is brachial plexus lesion, traction injury, or especially motocyclette injury, where young patients suffer from preganglionic nerve root avulsion is from spinal cord. In this case, it's no possibility to help him. Another nerve, upper and lower extremity, including sacral plexus, possible to help.
What about the lower arm, right about the elbow?
It's possible to reconstruct all nerves.
It's quite possible?
It's possible. Very important for people from rehabilitation, because time to time patients don't come in immediately, take time. And during the time, because paralysis starts contracture. If patient have severe contracture, the result is significantly less. Very important, especially for rehabilitation profession, to work with these people to prevent contracture using active, passive physiotherapy.
Okay, thank you.
You're welcome.